Check, check. One, one, two. Testing, testing. Music cut பண்ணிருக்கேன். Check, check. இல்லைண்ணா. Check, check. One, one, two. Test, check, check.
Check 1 2 3 4 5 6. Check, check, check.
Check, check.
after case only you had to tell. Hi, Narajan, Arun.
Hi.
This year also.
But then instead of 100, it will be I'm not running outdoors.
Right. On this note, Dr. Deepak, we go live and we're going to go live. I request the rest of them to mute themselves. Yes. We go live in 3, 2, 1.
Good evening to all of you. I'm indeed privileged to welcome you all to this webinar on Bifurcation Series, Day 3, wherein we discuss more on Culotte Stenting. We have 3 sessions today. The first one, Case in the Box by Dr. Vijay Kumar of Madras Medical Mission. We know him very well. He's the authority in imaging and coronary interventions. Vijay, welcome to this webinar. Then the second session, we have Dr. Goran giving the keynote lecture on tips and tricks in Culotte technique. And finally, the last session, we have 3 difficult cases, that is 3 Culotte cases wherein we had challenges being presented by very senior interventional cardiologist. Now let me also take this opportunity to welcome the moderators as well as my experts. As moderators today, we have the most senior interventional cardiologist, very respectable persons, Dr. Madhu Sridharan from NIMS Hospital, Trivandrum, and Natarajan sir, the head of the Department of Cardiology at Amrita Hospital. And we also have hardcore interventional cardiologists as experts, Dr. Kapardi from Care Hospitals, Dr. Arun Gopi from Metro Hospital, Dr. C.D. Ramakrishnan from Kannur Pariyar Medical College, and then Dr. Ravi Gupta, who is the senior cardiologist at Wockhardt Hospital, Mumbai. With this short introduction, let me request Madhu Sridharan sir as well as Natarajan sir to take over the proceedings.
Thanks, Deepak. I'm sure it'll be a great evening with lots of interesting cases. And first we have Vijay Kumar with the case in the box, and again Dr. Stankovic coming with the tips and tricks of Culotte. I'll ask Natarajan to say a few words before we start off the meeting.
Most of the meetings which my good friend Dr. Deepak organizes, they are very wholesome. It encompasses all aspects of a particular problem. Today he has chosen the very small aspect of bifurcation disease. As we all know, bifurcation is a very complex lesion subset, and we all see in our daily practice. A lot of times we are under confusion whether to do 2 stents, provisional stenting, etc. So we have had a series of lectures on when not to do a 2-stent strategy. Just stop with the provisional single stent strategy on the first day. Yesterday we had the most important discussion on DK crush. And today we have a competing 2-stent strategy, that is a Culotte technique. And last 2 days we have been very enlightening, and I'm sure today will be equally good. And without taking much time, we will invite Dr. Vijay Kumar to give his talk. He's going to share his experience in the form of a case in the box. Over to Dr. Vijay Kumar.
Thank you so much, Natarajan sir. Thanks for inviting. Thanks, Deepak sir and others for inviting me for this meeting. Can you see my slides?
Yes, very much.
Yeah. So we'll start this case in box. Sorry, this is not a fully recorded case. We didn't have an opportunity to record it. So you may find bit and pieces missing. So it is a routine case done. So I'm just putting for presentation here. So our patient is a 64-year-old female. She is diabetic,
hypertensive, and she presented with unstable angina. An echocardiography showed preserved LV ejection fraction. So this is an angiogram. I'll just show the angiogram. Maybe panel and moderators are invited to discuss this case. You are muted, sir.
Any other views, Vijay?
These are the two views which showed bifurcation better, and next one is RCA. I'll show additional views when we go for. This is a diagnostic angiogram of this patient.
So this is the left main bifurcation, isn't it?
Yeah.
Okay, so I'll make a small beginning. We can see some calcium in the proximal circumflex, in the proximal LAD, and the angle between, and there is a tapering left main. It's not a critical left main, it's a tapering left main. There is a small early OM or an intermediate branch, but it's very, very small, may not be of much consequence, deserving protection. So, but the circumflex is almost like a 90-degree angle or maybe 80-degree angle from the left main. And there is a wide angle between the LAD and the circumflex. And there's a critical osteal disease of the circumflex. And there's a proximal disease involving the ostium and the osteoproximal regions of the LAD here with some calcification. So that is the anatomy. Before I move forward, all I wanted to tell is the Achilles heel of left main angioplasty is the circumflex ostium. Oftentimes, all my fellow panelists and Dr. Madhu will agree with me that if the job is not properly done, oftentimes these patients come with circumflex osteal disease. So you have to really prepare the ostium of the circumflex with a cutting balloon, if necessary, rotablation, have a near stent result even before stenting the ostium of the circumflex, and have an upfront 2-stent strategy in this patient because the circumflex is very, very critical. So I presume that you will have ended up with a 2-stent strategy after adequate lesion preparation, aided by imaging. Madhu, you want to add some more points, please?
Yeah, it's a very interesting case, Vijay Kumar. I mean, this is what, most people dread. I mean, you have a critical lesion in the circumflex and calcium, and LAD is borderline. So, first of all, you would necessarily need to see if there's any FFR, preferably to see for reversibility in the LAD territory or is inducible ischemia in the LAD. Because if you obviously have to stent from left main to circumflex here, and that will definitely affect the LAD. So if the LAD is ischemic to start with, then obviously, I mean, you are much more justified in doing the case. On the other hand, if LAD is not ischemic initially, then the question would be, it's osteal circ. The patient is definitely symptomatic on medical management. Obviously, you have to do something. But yes, I mean, this is a difficult scenario which most of us would face, and it'll be interesting to see what is done.
Shall we also have opinion from Dr. Arun Gobi, Dr. Kapardi also before we move on? Dr. Goran also has joined us. Goran, sir, good evening.
Hello, good evening from Belgrade.
Good evening, Dr. Deepak. Can I have a few comments?
Yes, please.
Yeah, actually, a very good complex case of distal left main bifurcation, as Dr. Natarajan already described. It is a critical osteal circumflex lesion and almost near borderline disease of the osteal LAD and distal left main lesion, 1 Medina classification. Here, the most important, the angle is, it's a favorable angle more than 75 degrees. And the disease extending more than almost 10 millimeters from the ostium to the circumflex ostium, it is extending. So always here the upfront 2-stent strategy first you have to do. So depending upon the strategy of the operator, whether we have to do a inverted provisional or inverted Culotte we have to do. This is the thing, rather than the DK crush. Okay, thank you.
Hi, sir. Can I have a point?
Yes, Arun. Please.
Yes, Arun.
Sir, I fully agree with all these senior members, and there is definitely a critical ostial circumflex lesion which is causing the symptoms. LED definitely on the angiogram doesn't look significant, but obviously the whole picture will change once you have intervened on the circ. There is definitely a critical LMCA bifurcation disease. And when we think about treating this anatomy, this is again, as everybody knows, ostial circ is where we want to prepare well. As Natarajan sir said, get a stent-like result before you put in a stent itself. We do an LM to LCX stent and then reassess the LAD after the intervention. As Madhu sir said, with either an FFR or an imaging to reassess the LAD ostium after you have done a good, well-expanded stent from LM to LCX with a good preparation of the ostial circ with a cutting balloon and after a good post-dilation after stenting, reassess the ostium of the LAD after an LM to LCX stent with an FFR along with an imaging, preferably an OCT to look whether the struts are across the LAD ostium and then take a call on whether to intervene on the LAD or not.
Dr. Ramakrishna?
So Dr. Ravi Gupta has also joined.
Dr. Ravi Gupta, you want to, before Dr. Vijay Kumar proceeds, you want to give some expert comments?
Yeah, good evening. Good evening. I think the circumflex is definitely tight, but if you see the areocaudal view, I believe that LAD is also disease. So the primary idea was doing the left main to L6 is definitely fine. But looking at the LAD ostium, probably he would end up stenting the LAD as well. This is my opinion as prima facie.
Dr. Kaparthi? He has already said
Dr. Kaparthi had already said. Dr. Stankovic, if you could, give your inputs into this, that'd be nice.
Thank you so much. So I agree with majority of faculty here that stenting the circumflex first as the tightest and the area with the largest plaque burden is the first step in decision making. I will just put this in the context of the EBC philosophy. We don't need to decide upfront if it's 1 or 2 stents. We go until we achieve good results. So if we achieve good result with 1 stent, becomes 1 stent. If we need second stent, we put second stent. Having 2 stents is not mistake. So the only difference is that sometimes people prefer to do decay crash, stenting the side branch first. As European Bifurcation Club, we do similar. We will stent circumflex first here, but stenting from the proximal main vessel, from the left main into the circ. So it's sort of inverted provisional, but it's more or less the same as decay crash, securing the circumflex first. In this case, not just because it's we want to make procedure safer. It's also in order to compress the plaque, because plaque is distributed usually in the lateral walls of bifurcation. So in this case, most of the plaque is actually between left main and the ostium of the circ, and there is also plaque on the other lateral wall in front of the ostium of the LAD. So we go step by step. Seems that there is diffuse disease. We may end up with T-tap or culotte, but the first step to start is initially to do stenting from the left main into the circ, optimize dual kiss, and then evaluate the result. If we need second stent, a lot depends on recrossing cell. If we are able to cross distal cell and scaffold partially the ostium of the LAD, then we may discuss between T-tap and culotte. If the cell is not distal, but it's central or proximal, there is already some metallic neocarina, so we need to go for tap or culotte. In my case, I will wait for the decision on the second stent until we need the second stent.
Thank you. Thanks for the comments. Can you see something in the distal left main? I have marked with an arrow there. it is seen better in the cranial view that actually we missed it. So later realized that it was something else. So can you see cranial view? Something, some haziness is there in the distal left main. Just see that in the cranial view?
Yes, yes.
Or maybe an ostial part of the LCX is superimposing on your distal left main. I'll move on.
Sir, before, yeah, just a small query. Yeah. Just a small query. Do majority of us go ahead, start the procedure via the circumflex, do dilatation with a cutting balloon or a scoring balloon, stent from the left main into the circumflex, like what Dr. Arun has suggested, and then decide, do a pot, and then decide what needs to be done for the LAD. So will that be the strategy in majority of these situations, like what Dr. Arun and everyone has suggested? Or is there a small thoughts like doing an FFR of the LAD right from the beginning, or doing an imaging run from the LAD back into left main with an OCT or IVUS, looking whether the criteria satisfies that LAD also should be stented. The reason why I brought it was, in case we decide that we have to have a 2-stent strategy based on FFR or based on imaging, then when we stent from the circumflex into LAD, we can have minimal protrusion of the stent from the circumflex into LAD, so that finally, when we go ahead with whatever stenting strategy, the amount of stent that comes from the circumflex into the left main could be significantly reduced. Probably you can reduce it to 5 millimeter or less than that. But if our plan is to go ahead straight away with stenting from the circumflex into left main, you need to protrude the stent maximally into the left main, so that you need to have adequate amount of stent for a pot. But ultimately, when you end up having a 2-stent strategy, you have too much of stent, too much of 2 layers of stent inside the left main, so that the chances of future restenosis will be more. So what I had in my mind was decide on whether we are going to address the LAD with a second stent right from the beginning, rather than starting stenting the circumflex and then to decide on. What is your thought on this?
Yeah, exactly. That is what our plan also: prepare LCX, do an imaging from LCX, and do an imaging from LAD, and decide on stent strategy. That is what our plan. So RCA, again, you can just see that RCA completion sake, no flow limiting disease. Just go to, so here we are dealing with a patient, diabetic, unstable angina, preserved EF, mild to moderate RCA, diffuse disease, nothing focal. And we thought it is about 50% distal left main disease and 50 to 60% osteoproximal disease, the critical osteal LCX narrowing, ramus intermedius, again 90% osteal disease, but as we already discussed, it is not a very big vessel, and significant angiographic calcification. This is what, to summarize what we thought. And the procedure plan, an initial option of surgery was discussed with the patient. Again, patient was reluctant to go for surgery, and that's why the plan of going with the left main stenting. And femoral access, 7 French catheter.
Vijay Kumar, can I just ask a question? Why would you ask for surgery for just an ostial sac?
It is a left main bifurcation disease. We all know, again, this side branch restenosis is very common. And if it is a good candidate for surgery, I thought the surgical option also.
The surgery, but that would be only after doing an FFR of the LAD, isn't it? Only if the
yeah, absolutely. When we if the patient is for surgery, again, we have to assess the significance of a LAD lesion. So that's I'm going to show what we have done. Our strategy is,
Before Vijay Kumar proceeds, I just want to ask all the panelists and my fellow moderator, Dr. Madhu, how many of you really think that this will end up with a single stent strategy versus a 2-stent strategy? Based on the anatomy, with all your experience, I'm asking that question.
It almost certainly be 2-stent, because the LAD would be effective when you're stenting the circumflex.
That's correct.
Because you have disease in LAD. The only question is, we can probably wait and take it as a layered provision, as Dr. Stanko just saying. But almost certainly it will be a 2-stent strategy at the end of it.
But if you ask the question to Dr. Goran, he'll have a different take.
That's what he said, a layered provision.
In his experience in the EBC, will actually end up with a single stent. Dr. Goran, your opinion, please, before he proceeds.
Yeah, but I'm not saying it's fault to have 2-stent strategy. I just say it's not relevant to decide whether you need 2 stents or not. Okay. Step number 1, in any case, for us, is the tightest and most angulated lesion first with the largest plaque burden. Will be with or without imaging. Of course, there is always big plus for imaging. For physiology, I'm not so sure because tight lesion at the ostium of the circ make interpretation of FFR in the LAD obscure. But imaging to plan strategy, I think it's good. But in any case, I know there will be second stent most probably. I just don't need to say and doesn't make any difference. I'm not going to stop to finish before I optimally achieve optimal result. Whether it's with one stent or with two stents, I don't think there is need to discuss in advance. According to EBC main, 22% approximately needs two stents, but depends on the patient and lesion subset. This kind of patients was not tested in EBC main nor in the DK Crash 5. You know, these are the patients that we need to individually discuss all the options, and then we follow the operator giving our comments. But I'm sure at the end we will have optimal result, and let's go through the steps so we can give comments throughout the procedure.
Sure. Vijay,
yeah. Femoral access, 7 French guiding without pre-dilate. The solution looked very tight with a small balloon because we are not sure whether the larger balloons will track in. And further preparation with NC balloon and scoring balloon, and OCT imaging of LCX and LAD, and LAD preparation based on OCT findings. If it is significantly narrowed, then we thought we should prepare with the SING. And if it is a two-stent strategy, Culotte was our stenting technique for this case. And as we already discussed, ramus intermedius is not a big vessel. To avoid complexity, we decided not to intervene ramus intermedius. And the left main coverage, whether you have to extend up to the proximal left main or ostium based on the proximal extent of the disease. And this
just a short question. The conventional teaching is if the angle is 70 to 90 degrees, tap or
tap or B.
Here it's like a 90 degree, but you said in your plan that you're planning Culotte in case two stents are needed. Any comments?
Yeah, this is actually because it is anyway you have to do this thing. From LCX to left main first. Then we thought maybe rather than T and this thing, it is better to do a Culotte because your plan is to do a reverse Culotte or inverted Culotte, whatever you call it as.
Okay, fine.
Yeah. And this is what the LAO caudal picture showed. This again, I didn't show earlier. You can see the some haziness in the distal part of the left main and the proximal LCX. Can you appreciate here the haziness?
Yes.
Yeah. Okay. I'll proceed if you're okay. And we used 2 wires as in any bifurcation, and LAD was wired with BMW guide wire, and LCX we used cyan blue. We thought it would be a little difficult to wire it, but reasonably easily it went in with a cyan blue wire. And we used a 2 into 15 NC balloon and dilated the side branch. Balloon again, not very difficult, but easily went in. And the dilatation, I'm not sure whether you're able to appreciate in the screen. We dilated to about 1820 atmosphere with a 2 millimeter balloon. And as we already discussed, went ahead with a 312 balloon here. Anybody wants to make comment here?
Yeah, there is a plaque shift to LAD, I believe. Probably once you ballooned with a 215 balloon, or would you able to manage any cutting balloon or scoring balloon before that?
Or
it was difficult?
It is first we thought with, again, it is cost. I don't know how many balloons and these things we are going to use, but we started with an NC balloon. You are happy with this dilatation?
How much? What pressure, sir?
It is 20 plus pressures.
Because it's still significant waste there at the ostium of the circ. Significant waste.
Yeah, significant waste was there. So we went ahead with the scoring balloon, 310 scoring balloon in the ostium. Looked like it is reasonably expanded, and just see that angiographically also it doesn't look very bad, right?
Yes.
So if you're okay, can move on.
So after the scoring, do you prefer to go with a semi-compliant at good pressures to see whether there is a residual waste one-on-one size to see whether it is well opened up?
Yeah. Anyway, we are going
imaging.
to with an imaging, so
Yes.
we can reassess it. So if you're okay, no comments. Shall I move forward?
For the younger colleagues who are logged in, is it safe to cut with a wire in the left main to LED?
Oh yes.
So it is a scoring balloon. It is not a.
Okay, fine.
But
It's not a cutting balloon. What about with the cutting balloon?
No problems, Nataraj.
It's also safe with cutting.
If
It's okay.
people do it routinely, I don't think there is any big problem. But it is not a cutting balloon; it is a scoring balloon.
Even a cutting balloon is safe?
It's safe.
Yes, it's safe also with cutting.
All right.
Okay, I'll move forward. So we did OCT imaging from LCX to. Can you people see the OCT imaging?
Yes.
As a small screen, not in the big one.
Yeah, it is. Maybe I'll just show you still images. But if anybody wants to make some comments, I'll replay it if you want. I'll just go slowly.
Oh,
so this is from mid part of the. Okay, you can appreciate here. There's a lot of calcium, right?
Yeah, a lot of calcium.
It is, but it's not very thick in places. So we just went through it. It's not very thick, and everywhere we had a calcium. Even though some places it is very thick, but in all the frames there is an area which is less than 0.5 millimeters. You just keep seeing here, and again, see there's a lot of calcium, 270 degrees here almost. And here there's a small side branch. And again, it's not very thick. You can just see that it is about 0.5 millimeter here. And this is thick. But hopefully this area should give way. Whether now we have to decide whether you have to do an atherectomy or not. But it is reasonably okay. And till this part, do you want to make any comments here? This is calcified nodule protruding. And this is what endosteal LCX. You can see the cuts here. This area is cut, but still the big calcium nodule sitting here, and it was extending into distal part of the left main. So you can see that LED wire is coming here, and this is your distal part of the left main.
Vijay, generally, Vijay, before doing an OCT imaging, we dilate the lesion if it's a very critical lesion with a 2 millimeter or if at all a 2.5 millimeter balloon, and then go ahead with imaging so that we get an idea regarding the morphology very clearly. But then you even went ahead with a scoring balloon.
Yeah, because we were not sure whether the catheter will be able to, you will be able to track the catheter. So we thought if the lesion prepared well. And then again, to avoid too many OCTs into the, so suppose if you find something, then again, you have to do. That's why we thought, anyway, it looked like angiographic 3 millimeter vessel. You just prepare with the 3. If it is bigger, then again, we can go ahead with the bigger balloons here.
The concern was tracking the OCT catheter into the lesion before it's well prepared.
Yeah.
And one more thing, Vijay, when you have this kind of tortuosity with tight lesion and calcium, many times you've seen that with OCT, there's not enough dye clearance and you don't get good pictures. Is that the same?
Again, that is again another reason. But as Dr. Deepak said, it is 2 to 5. It is fine to get a good clearance with OCT imaging. But here, it is even balloon, other things, we had some difficulty in crossing it because it is not a live case. You didn't appreciate it. It was a little difficult to, whenever you just retract the balloon, you would have seen that guiding was just backing out from this thing. Left main, even though it is a supportive guide, still it was backing out. We actually placed a long sheath also for this patient. And if you move forward in the left main, and you can just see that, I'm just going to show still frames. This left main also has calcified, but not very extensively. And approximately the vessel looks okay, so you don't have to really extend to the ostium in this case. And I'll just show you some of the still frames here. Can you appreciate the still frames now?
Yes.
So if you see this thing, so this is your proximal landing zone, the left main, not very big because it's a female patient. 3.75 is what the EL to EL measurement in this patient, and this is a distal part of the left main, not very bad. And this is again calcified nodule protruding in the distal part of the left main. This is osteal LCX. You can see a big chunk protruding here, big chunk protruding here, and these are the things what I was explaining. It is not more than 0.5. So how do you proceed here? And this is the findings: osteal LCX, nodular protrusion, plate tape calcification distally, and thickness is about 500 microns. We're not talking about nodule, it is about plate calcification. About 500 microns and 270 degrees. And the 3 millimeter was what is our distal reference, EM to EM, and 3.75 was a proximal reference. If you have to extend from distal reference, if it is a 2-stent strategy, it is about 16 millimeters of what the stent we need. And based on this OCT findings, we need additional preparation. Any comments here?
Yeah. There appears to be some more work done for optimization of the result in the circumflex ostium.
Yeah. So there's more calcium even into the proximal circ beyond the area where we dilated as well.
Yeah, absolutely. Yeah.
Yeah, and there is still a significant amount of deeper calcium. So better preparation with an IVL or shockwave lithotripsy would give you more luminal gains before placing in a stent.
It's a nodular calcium, isn't that, Vijay?
Yes.
So what kind of preparation are you looking? Because IVL for nodular calcium is not really great, and a rotablator, I'm not sure, unless you have a good bias, you would get a good result.
Yeah, not rotablator, I'm not very sure. If you see that imaging catheter is not hugging to the calcified nodule, and unless you alter the wire bias with adjusting your wire position. And orbital atherectomy, they say that you just go in, when you come back and ablate it, this type of calcium, it cuts very well. But unfortunately, we don't have any experience with that. Even it was discussed yesterday in the meeting. And any other comments or any other strategy you just
you shown very nice OCT images, and I believe that there are 2 findings. One is the calcium is covering almost more than 50% of the circumference. Another thing, there is a big nodule of calcium. So in any case, you would require probably an IVL plus minus rota. Plus minus rota. Maybe that you are not able to do the whole job with IVL alone. You may require rota as well, which we call rotatripsy, but probably we should give a try with IVL, and after that we should repeat one OCT. This is my take on this case till now.
After preparation with the 3O scoring balloon, would rota give you a cut with even with a 1.752? I believe is very difficult to get actually. So with on the other side of the carina, the circ part, the nodule, how easy would it be to cut, to get a wire bias there?
Usually, if you see the Japanese operators, what they do, this type of calcium, if it is very tight, they use a rota, maybe a 1.25 or 1.5 to just get entry into the distal part of the vessel, and they use orbital atherectomy, because orbital atherectomy per se in a very tight lesion is very difficult to do it. Then what they do, the pull back ablation, that is when this inner whatever you call it as side of calcium gets cut very well. So that is the ideal thing they describe for all this eccentric type of calcium involving left main LCX. But unfortunately, we don't have that. IVL again is maybe a good option, and I think recent study, if you see that disturb series, it has shown that even use an IVL even in a calcified nodule, you get a good compression. They call it as when you see the good expansion on fluoroscopy, and you see the non-OCT, if it is a nodule is well compressed, that is when you get a good stent expansion. So that is how this IVL definitely works in the distal part. Distal part, I didn't think IVL is essential, because it is most of the places you find, there are places which are less than, each frame less than 0.5. So unfortunately, we didn't have IVL that day, because we just underestimated the extent of calcium in this patient. Because IVL, we had to tell the people.
Can I just ask a question? Here, because distal circumflex is well open, you don't need an IVL. All you need is for a nodule. For nodule, would you really need an IVL?
this recent study it has shown that I think it has been presented. It works in nodules, but not to the same extent as in circumferential calcium. And it is almost like an eccentric calcium. It works. So they say that compression. So how much compression you achieve with it. So they say that the top part is friable. You can just compress with your balloon or IVL. So that is when you get a D-shaped stent expansion, but still it is adequate stent expansion. So unfortunately,
Vijay,
we didn't have both.
Vijay, 1 second. Vijay, just wanted to have an opinion from Dr. Selmani also. We see in these images that is E as well as F. You could see in E as well as F images, frames, that the imaging catheter is very close to the peak of that nodule. So if at all, because we know that there are no many options to manage this, and we also know that we open the 3 millimeter scoring balloon very well. So hoping that one thought would be just go ahead with a non-compliant balloon, higher pressures, hoping that it would definitely open up because the scoring balloon opened up. Secondly, if somebody is so much bothered about doing a furthermore lesion preparation, would Dr. Selmani, what is your opinion on this? Would you go ahead with a 1.5 millimeter rotor burr, hoping that you might shave off little bit of calcified nodule? What is your opinion on that?
Yes, Deepak and Vijay, my personal feeling is because it's the ostial of the circumflex is very important, and many times you get such a calcified lesion, with significant nodule there. When you see many cases, whenever there is a nodule like this, if you don't prepare it properly with, for example, like a rota or something, your final outcome may not be so good. You will have really not a well expanded stent at the ostium of the circumflex. One. Yeah. But my experience, what I feel is, see, all nodules does not react in the same way. I have had cases similar like this, where with high pressure or cutting balloons, we have managed to get a stented area, which is very decent or reasonably good. But similarly, I have had cases where we were unable to expand and we had under expansion in this area.
That's again very important.
Yeah, just based on this OCT, predicting the outcome of a calcific nodule is very, very difficult. But in this specific case, I would definitely do a rota, and probably hoping that we will get a good stent expansion and we can modify this nodule.
Yeah, and if you see that OCT, even where the calcified nodule is there, you can just see cuts, right? Are they just where the calcified nodule meets your regular vessel? So what our thought process was, we just again go ahead with a non-compliant balloon. If you get a reasonably, I don't think you'll get a proper central location with expansion all around. So that is not possible in this type of case, because this nodule, whatever you do, doesn't allow the balloon to expand well. So we thought we just do additional balloon dilatation. And if it is a reasonably expanded in 2 views, it's just orthogonal views, we have checked it. If it is reasonably expanding, then we thought we just proceed with that for stenting. So this is what the expansion we got. I can't say, you just see that we observe the balloon here, it is an eccentric expansion. So this type of thing, then if you keep doing it, sometimes there is a chance of rupture also. So once it is a reasonable expansion, then I thought we should accept it. And an additional preparation was done for your LAD also. We have only 23 minutes. Maybe I'll just go through this thing, then maybe when important thing comes, then we'll discuss. So then after preparing this one,
Vijay, small question.
Yes, sir.
You had any OCT run of LAD before?
Yeah, I'm just going to show next.
No, before
so
the preparation. Before
no, we have not touched the LAD at all so far.
You have the last
image. Okay, this one. Okay. No, that actually this that OCT was done before this, and I'll just show you that.
Okay.
So this is the LAD. You can just see that LAD. You can just see that this is your ostial LAD part. It was only, you can see that it's not disturbed. So it is actually the images, balloon images were different. So just see that here it is a 2.6 millimeter square was ostium. So again, it is a significant lesion, even though we don't have any data for left main bifurcation. If you have a side branch with more than 50% block burden and your area less than 4 millimeters square, that is considered to be significant. That is when your FFR will turn out to be positive when you do single stent strategy. So based on this, then we thought it is straight away to stent case. And if you see here, there is
there a nodule in C?
Yeah, nodule. You can just see nodule here, and this is the distal part of the left main, and this is the proximal part of the left main. So again, 3.75, and distally not a very extensive calcification. Whatever we had, it is all about 90 degrees to 180 degrees. And suppose if you have to stent from LAD to proximal left main, we would need a 28 millimeter stent. And again, my reference was 3 millimeters. Any comments on this thing?
Vijay, regarding these images, further classifying that calcium, looking at B as well as C frames.
Yeah.
B, would you call it as an eruptive nodule, and C, would you call it as a nodular calcium?
Nodular protrusion. So I didn't want to confuse people, so by calling different names, so that is what it is called in recent classification. And the eruptive nodule is the one what Dr. Salomoni was describing. Most of the time, you just, because it is all fractured calcium, and the nodular calcification most probably a little bit more organized. Eruptive one is the one which just gives way to your balloon dilatation or IVL, whatever you call it as. And this nodular calcification, I think even IVL doesn't work in a great extent.
So Dr. Tom Devasya as well as Dr. Ramakrishnan has joined us.
Hi, Tom here. Great case. Just wanted to give, I have had some discussion with Japanese operators, and like Dr. Vijay Kumar said, one effective strategy, what they do is if the circ ostium is having heavy calcium, which does not allow easy passage of scoring balloon, they will go ahead with the rota there. And instead of passing the rota, they say they just sit at the circ ostium and then kiss it in and around for a little longer duration, so that the chances of the calcium nodule getting more ablated is more. That works out to be a good strategy. So my working strategy is, in case the patient cannot financially afford, or I have not explained in advance about the IVL, what I would do is I would just go at the circ ostium and just sit at the ostium and ablate for a few extra seconds, so that my passage of scoring balloon is much more easy, so that my end post-standing optimization is more easy for me. Thank you.
Talking about static rotablation. He's talking about
Vijay,
rotablation.
Yes, sir.
Is he talking about static rotablation, Dr. Tom?
Yes.
Okay.
Yeah,
But I
Vijay,
would like to know the opinion of Dr. Goran. What does he do if there is a circ ostium, significant calcium? What is his strategy?
Yeah, we have both rota and IVL, and it's usually rota to crack and then NC balloon because of the cost. And if it's really deep calcium or nodular, we prefer to use IVL. Although results are not superb, at least in the perspective of anecdotal cases, this is what we learn from others.
And if you see that the vessels are not the usual size, you would love to have 3.5 plus in this thing and 4 or 5 in the left main. But it is being a short statured female, it is a 3 and 3.75 was the size. So if you know comments, I'll move forward. We have only 19 minutes to go, so it is. So we stented into LCX with a 316 millimeter drug-eluting stent. And I'm not sure whether you're able to appreciate, even I cannot see clearly because the contrast is not enough in the stent. So I'll show you some pictures. Then after that, we did a part. Any comment on this part? And I'll show you the extent of the stents. It's not, it is like whatever you call it as, it is not somewhere between mini culotte and culotte. So it is.
Yeah, it's almost like a mini culotte. It's around 5 millimeter into the left mid. So
you
have an area of geographic miss anyway. You're going to
stent. Fine. Anyway, I'm just going to stent more proximally. And any comment about this part? Then again, we didn't realize that time. You can see that balloon was not extending to the carina at all. Can you see that? It is not extending. And we
thought probably we can see that balloon is in the unstented part of left main as well.
That is we are planning to stent proximally, so but it is a 6 millimeter balloon, so that is the shortest we had. But it was later again. It was realized later it was not extending to the carina part. That is actually it is not the correct part, but we did it. And we used the same LED wire. It is, again, it may not be a great strategy. It, again, cost saving one. So ideally you should have kept the wire there and used a third wire to enter your LED. So jailed wire better once you prepared a lesion, better not to remove it. But
would there be a choice of the stent, Vijay?
That was a Synergy stent 316. And it wired. So now what do you want to do it? We hope it was a distal stent. It looks like a distal stent, right? It was very close to the carina when the crossing point. So we thought we just confirm with the OCT imaging first the expansion of your LCX stent and your crossing point. Any comments here?
Yeah, you can.
So my distal reference was 5.2 millimeters square. And if you see that MLA at the LED ostium was 5 millimeters square.
Yeah, I think in the OCT run, it's clearly visible. There are multiple struts across the LED ostium.
Yeah.
So probably you need to recross it and at least do some kissing.
No, it is actually we had decided to do with the second stent because LED ostium was hemodynamically significant by our OCT. Yes. So any comments on this?
Vijay, this is what you explained. The balloon was not reaching till the carina because you're seeing that near the confluence, it's floating there.
Yeah, it is floating here. And but see, for any two stent beams, any recrossing, you need the proximal part of the stent to be, of course, not the distal part. We are not too much, but unless if you're worried about crossing through this thing when you recross from here, but that highly unlikely to happen. So we didn't attempt redoing it. And if you see that it is, even though it's not very clear, and you see the strut morphology here, it looks, see here, you can see a connector here. Most probably there is no connector here. So it is the link-free carina. And if you see here, the wire is going through the distal part of the strut. And if you want, I can just show you the image here. If you see that, you have to see the wire close to the carina. So distal part of the stent here, you can just keep seeing. It is actually, this is where the carina and the wire crossing is very close to the carina. So even 2D imaging wise, it is a distal crossing. And it looks like the stent morphology is favorable. You can just see here, there is a connector here. Most probably this is a connector-free cell.
Sir, can you just elucidate on for everyone which is your preferred cell to cross or strut to cross?
Yeah, this is a cell. So you can just see a connector here. This is a two connectors cell stent, when highly unlikely you have a connector here. So it is most probably a link-free carina type. And the wire, you can see that it has gone through that cell. You can see in the long view, this is not actually, it is the system not recognized properly. And if you see even 2D wise also, it is coming just closer to the carina. So it is most probably a distal cross. And another important thing you have to see is whether the proximal part of the stent is supposed. That is the most important thing to avoid abluminal crossing of your wire. So that is the most important. It was covered. And our expansion was not very bad as we thought. Your distal reference is 5.2. I was expecting 90% of this 5.2 at the ostium, and it is about 5 millimeters square. That is what we got in the ostium. So I'm done with LCX. So we are just going with an LED. Any comments?
Vijay, the nodule part is still compressed now. So would you do a DK culotte, or would you just go ahead with the regular culotte?
Yeah, it is an again DK culotte, but this ostial part of the LCX is, as per the criteria, it is expanded. Any comments?
What is the MSA there?
See, my reference is 5.2 millimeters square in the LCX. And my ostial MLA is 5 millimeters square. I achieved more than 90% of the expansion which was needed, even though it is a D-shaped expansion, and there is obviously there will be a malposition when you have nodular protrusion inside. Any comments on this?
Any opinion from Dr. Goran whether he would use an OPN balloon to get more spherical rather than D-shaped at the circ ostium?
Yeah, since we don't have any really relevant clinical evidence to achieve this spherical instead of oval shape, I would personally not use OPN. I mean, first, it's extremely costly device. Second, if you look CT scan, polygon of confluence is anyway oval shape.
Yeah.
You know, so it's
I thought
there
maybe
is no need to insist.
Yeah. Another risk here is you just see that I'm no way going to compress this one further. I'll be expanding on the other side. There is some possibility of even rupturing your vessel. See, this is a situation where you get a reasonable amount of expansion, just to don't overdo things and end up, if you rupture this area, it is the most difficult situation to deal with. So once you're sure with a reasonable amount of expansion and you're done with, and you're always end up with some malposition because this calcium doesn't allow you to go to the vessel wall at all. It's okay, and we have only 10 more minutes. I'll proceed further if you're okay. And this is what we got: distal left main malar post, stent stud, and nodular protrusion, D-shaped stent expansion. LC SMLA is 5 mm square, and a link-free carina type and distal crossing. That's what observation from this OCT. So we dilated with a smaller balloon, then with a 312 balloon, NC balloon in LAD. And we didn't cover the ostium, but we covered the area what we dilated with our hot balloon. And this is a 328 Zymes stent that is implanted. We would love to have the same stents, but unfortunately we didn't have a similar size with a Synergy. So we used, and then unfortunately the other side also we didn't have a similar size with Zymes. So that's why we have to use 2 different type of stents. So then part was done. Sorry, it is all low fluoro. So can you see part here? So part was done with the same balloon at high pressures. And this time we made sure that it is extending it just in front of the carina. And we recrossed into LCX from LAD, and looks like it is a distal cross. It is close to the carina. Again, you have to be very careful that you don't cross behind your stensors. That is where you have a bad area at the carina. So that should be avoided.
And Jay, when you do the pot, do you do in the iliacaudal or do you do it in multiple views?
We see 2 orthogonal views, but if it is iliacaudal is most preferred view. I don't know.
But iliacaudal will be foreshortening, isn't it? That's why I asked.
Foreshortening, that is where you can see the LCX ostium clearly. So that is one, I just want to cover it and get into that. But always it is a better idea to see 2 orthogonal views. Whenever you do part in any vessel, 2 views, and distal marker should be an appropriate position in 2 views. So that is what the recommendation is. That is what has to be done. And we recrossed into LCX. And so we did an OCT imaging. Any comments from experts here? Crossing position, just put even fly through. If you want, I can replay it. Again, you see that strut morphology, again, looks like as a link-free carina type. Fortunate enough to have, you have a link here. So this strut, you are not expecting to have a link. And this is a distal crossing, and this is distal crossing. And here you can just see the wire here. So this is a distal crossing. And if you see your images, and here also it is going through the distal crossing and wide open cell here. So any other comment? Otherwise, I'll move forward. We have only 8 minutes more to finish the case.
Vijay, is that a survey mode or a high resolution mode? Because the stent struts are looking dot-like, appearing dot-like.
It is a high resolution mode, but still, maybe I think it is all hand injections. But you can see the stent struts clearly, right?
True, so very clearly.
Very clearly. And ideal to use a 54 millimeter pullback if you want to have a stent imaging. That is what the recommendation is. So again, distal crossing, we just dilated with the 215, and this is the stage. Once the balloon crosses, you have to make sure doing a stent boost that you are inside the strut, not outside the strut. So it is done. Once you confirm with that, and you are done dilatation here, and again with the 3 millimeter balloon, and a kissing with the 2 3 millimeter balloons. And here it is a high pressure balloon dilatation, and this is your kissing balloon. I'm not sure whether you can appreciate it is 2 3 millimeter balloons. It was a sequential and a simultaneous side branch, main branch, then side branch inflation and main branch inflation and simultaneous.
What pressures did you go to?
Means sequential, it is 18, 18, and simultaneous with 12, and simultaneous deflation. I think the current preference is to dilate the side branch first, then main branch, then deflate simultaneously. I think that is what the EBC also recommends. And again, we did a final part with a 3756 same balloon. And maybe directly I'll go to the imaging. So any comments here? And this is what we got. Our distal reference again, here it is 5 millimeters. You can see a small dissection. So it is non-consequential because your lumen area is good, even though it is going to media, but it is a very, very small dissection. We just left it alone. And our distal reference is 5 millimeters square, and LAD minimal lumen area is 5.8, and ostial part of the LAD is 6.2 millimeters square. Even though it is oval at the polygon of confluence, we got an area of 8.8, and in the left main MLA is 10 millimeters square. You can just see that nicely distributed stents, and if you see the fly through, there is hardly any sets across the LCX ostium. I had one or two, I can just see that it looks well opened. LCX ostium, and you just see that here. You can just see that it is not the abluminal position. You can see the stent studs attaching to your carina side. And what we wanted, a few things. One is your coverage of side branch ostium that was achieved, and reasonable or good expansion of side branch coverage, and not much of neocarina here, and well expanded left main LAD L6 part of the stent, and overlap is about 4 to 5 millimeter here. Any comments on this OCT? Are we?
So how much is the double barrel in LM actually with the Culotte?
It is about, you can see that it is extending up to this one, maybe about 5 millimeter here.
5, 6.
Yeah, 5 to 6 millimeters here. Here even you can just see the 2 layers of sensors here, and there's a nicely distributed giant stents, and not, I think hardly any cell this thing. And the other thing you're worried about is abdominal crossing. That was you can just see that sensors are here, so that is not the case. And this is what the final result. And OM or your early means your ramus is TIMI2 flow, and I can't say great expansion angiographically, but the lumen areas are adequate. So to summarize, Medina 1-1 angiographic left main bifurcation, equal sized branches. We selected a Culotte strategy. OCT helped in lesion preparation, LC calcified nodule, plate type calcification, and not much of calcification in LAD. And OCT helps in device sizing, stent appropriate stent recrossing, and stent optimization. Thank you. Any comments? We have 4 more minutes to go.
So there are 2 questions in the chat box. So there are 2 questions in the chat box. The experts as well as moderators can comment on this. Number 1 by Dr. Ramchandra Naik. For these sort of complex interventions, what would be the ideal way of puncturing the femoral? The conventional technique under fluoroscopy, or is it ultrasound guided, or is it like what Vijay has done using a micropuncture technique? That's number 1. And the second question by Dr. Ramesh Natarajan: will inverted T be a choice if the circumflex is little smaller, something like 2.5 millimeter in this situation?
I think inverted T was choice right from the beginning. I mean, I was in the impression that LAD is significantly diseased. I mean, if you say 50-60%, but to me it looks like that the left main distal was diseased for sure. The LAD was significantly diseased. I won't say that it was 70 or more, but it was looking that it would require a stent. I mean, this was my initial impression before the OCT. Another thing, if we are planning for in this situation, I mean, this is my take, in that situation, probably inverted T would have been a very good idea, in which we could prevent metal which we used in Culotte. So we could put one stent straight from left main to LAD, and then you keep a balloon in the left main to LAD and put another stent in left main to L6. This is my suggestion.
But is there a small possibility that you could close down the circumflex while putting in a stent from left main to LAD? Because it's critically diseased.
Yeah.
And also the recommendation is to deal with the more angulated vessel, and that too with a critical disease of this nature. It is definitely wiser to stent from the left main to the circumflex first, as was done in this case.
Vijay sir, excellent demonstration. Just a question, based on what you showed, do we still have evidence to deal it with a two-stent strategy just because of the OCT area of the ostium of LED looked less than 4? Is it evidence-based, or you would have been happy to have a physiological assessment as well?
Yeah, we could have done that, but this is based on the study from Korea, which has shown that any left main which has more than side branch, it's not LED, it is actually an assessment of LCX, which is more than 50% block burden, and an area I think it is 56%, and exactly to 3.7 millimeter square. If you have less than that, highly likely you end up stenting the side branch. That is where your FFR will become positive. So based on that, we don't have. That is the only study we have. That is from.
That is for ostium of circ, or for
it is for ostium of this circ. But
for the ostium of circ.
And LED should be even more important. Even bigger areas you may have to stent. It may.
But that was IVUS data, right, Vijay? That was IVUS data.
See, most of the places we just extrapolate IVUS data to OCT. It's not. It was, I think, way back in 2010 or 11 was that.
No, but whichever way, I mean, even if you're doing a provisional strategy, I mean, you would probably have to open the stent struts and do a kissing balloon into the LED, and after which you probably would have to blend it up.
If you see the block morphology and other things, highly likely
you had a calcium nodule in LED as well.
Yeah. And any other comments, Dr. Goran? You want to make any comment?
I don't have specially additional things to add. I just would like to congratulate on fantastic illustration. This is for the book, how to do OCT guided step-by-step culotte in the calcified left main. So I enjoyed the case very much. Nothing else to add.
What was the clinical follow-up of this case? What is the clinical follow-up of this case?
She's set to complete 6 months. We don't do any stress tests or anything unless patient is symptomatic. I hope she does well, but still, if she comes back, well, then we have to see what is to be done.
Yeah, meeting.
Dr. Vijay. Dr. Vijay, can you hear me?
Yeah, I can hear you.
Yeah. Because in this case also our angle is little wider. So still, why did you prefer culotte rather than crush?
It is a personal preference. We felt culotte might be much better than T in this situation, at least. We can't say if you had a soft block at LCX and still easily crossable, T would have been because it is close to 90 degrees. But in this case, personally, we felt it is culotte might be a preferred strategy. We didn't even think a double kiss crush in this case. Maybe I'm not sure. Deepak and others might have done double kiss crush in this case. I'm not very sure. And our preference for this case is for culotte. It is again personal preference. I think again Dr. Goran insists every meeting that stent strategy is not important. What you get in the end, if optimal result, whatever stent the strategy you do it. I think that is ultimately the thing that we have to just realize. I don't think even if you say that double kiss crush is good, if you don't do it optimally, I don't think you end up with the good outcomes. No other questions. We'll move forward, sir. 8-2 now.
Yes. Excellent.
Thank you so much.
Yes. The next, I think we've got the much awaited keynote lecture. We've got Dr. Stankovic to talk to us about the tips and tricks of Culotte stenting. It's been a great honor to have Dr. Stankovic with us for 2 days, and he is the president of the ABC, and we all look forward to hearing from you, sir.
Thank you very much for the kind invitation and for the kind introduction as well. As you mentioned, my major conflict of interest is being the board member of the European Bifurcation Club. So I'm influenced by the consensus documents coming from the club. And what I'm going to share is just a couple of examples of the culotte and couple of tips and tricks that were discussed during the last 17th meeting of the EBC in Brussels last October. I will come back just as introduction if some of the attendees did not listen to Friday and presentation on provisional. This is the MEDS classification of stenting techniques by the European Bifurcation Club. And I would like to point out that when we discuss provisional is actually A class of the technique, and DK crash is S family of the techniques. M and D are very rare. So the major difference in approach to left main PCI in general is whether you stand from the proximal part of the main vessel or you position your first stent in the ostium of the side branch. And I already discussed that provisional is for us stepwise layer strategy in which there are multiple steps starting from stenting of the left main into the LAD or from the proximal to distal part of the main vessel. Then we routinely do POT, and this is the first point in which we evaluate the result after POT, because POT is mandatory in order to oppose stent proximal in the proximal part of the main vessel. Then if we want, we can do side branch opening, but in that case, because of deformation, we recommend to repeat with kissing, correct this. And if we need second stent, and as I tried to mention, it's nearly not rhetorical. If we need second stent, we put second stent, and there is no mistake or fault by using two stent strategies. So I would like to use this opportunity and my frequent presence in meetings worldwide, especially in several webinars organized by colleagues from India. I'm not against DK crash. I just think that provisional gives you variety of options. It's preferred strategy in Europe. We are all trained to try to minimize the number of stents and therefore metal that is used, because my good friend Jens Lassen says if you start with one stent, you can always finish with two, but if you start with two stents, it's impossible to finish with one. So Culotte for us is a sequence of provisional or sequence of inverted provisional. In this case, you start like in the case that we saw, stenting from the left main into the circ, and after that we put second stent as a culotte. In our consensus document in 2020, we wrote that we consider electively two stent strategies for long and diffuse disease or high risk of compromise or difficult side branch access. However, if we plan two stent strategy, for example, in the case before I said, most probably we will finish with two stent strategy. Our approach is always provisional stepwise. In this case, inverted provisional, finalizing procedure with culotte. As a sequence of provisional, it's mistake to say it's a bailout, because in this case, culotte stenting was sequence of provisional, was not bailout. We just identified lesion and disease in the ostium of the LAD that was nicely covered with the culotte and confirmed by the OCT. Of course, we accept DK crash as the option, and in another consensus document from EBC that was dedicated to left main treatment, we mentioned culotte as part of the complex diffuse disease 111 or 011 through distal left main bifurcations. I just want to share with you that in the EBC main that was commented also today, and that I commented in details on Friday, in the provisional arm, 22% of lesions were stented also in the side branch. But if we go to systematic dual stenting, we see that 53% of all plain two stent strategies was culotte, which really reflects for you the nature and the philosophy of the European interventionalists. And then we have another 1/3, 33% of T and TAP. So in total, almost 90% of cases of systematic two-stent strategy in Europe is Culotte, T, and TAP. We rarely use DK crush, although it was permitted. It was used only in 5% of cases. So how to do Culotte? Again, animation which I prepared myself with my colleague. So we wire both branches. This is LED diagonal, for example. We predilate both. This is classical Culotte. So we stent LED, we do pot to optimize, and then we recross distally. After recrossing distally, we open struts, and then we can do kissing, which becomes DK Culotte, or we just stent with minimal protrusion long enough that pot will oppose and touch the opposite wall. Then we do second pot, again cross distally, high pressure sequential inflation, and then simultaneous kissing, and the third final pot. So this is the result. And you see, if you do classical provisional, you have minimal 2 layers overlap proximally, and you can really easily decide on the length of protrusion from the side branch into the main vessel. This is one of the first cases of Culotte with the EBC philosophy behind. This patient was randomized for EBC2 study. EBC2 study was our first European Bifurcation Club comparison of provisional with planned two-stent strategy in big side branches. You see in this case really diffuse tight disease in large diagonal and lot of calcium and disease in both LAD and diagonal. This is the vessel contour and this is the lumen contour. So we start by predilating both branches in one. Some operators may say you predilate one by one. Then this is stenting because of the angle and large plaque burden from LAD into diagonal. Size, of course, according to diagonal. Pot, after pot, rewiring distal cell and opening of the struts toward the LAD. This is, at that time, a long proximal overlap between both stents. So this is like full Culotte, not mini Culotte, but the steps are the same. Again, pot after second stent, and after that, two-step final kissing, high pressure individual inflations, and then simultaneous, and then pot number 3. And this is good final result with good opening towards the both branches. And one more recent case of, again, inverted provisional Culotte, 80 years old gentleman with risk factors, prior MI, prior CABG. He has reduced LV function as well as GFR, but he had class 2 angina under full medical therapy and was submitted for coronary angiography. I said also prior ICD was implanted. These are the still frames images showing short but significant 1-1-1 disease in the distal left main, and functional significance was also measured, and the LAD showed FFR of 0.79. So here we see the diffuse disease predominantly in the distal left main ostium of the CIRC, and relatively short disease at the ostium of the LAD. Then in another projection, we see more this distal left main and ostial LAD. So the strategy, again, patient was randomized in the EBC main, and randomization was 2 stents. So decision was to start with inverted provisional stent, predilating, of course, both branches, but then which branch should be stented first, more angulated, more diseased circ. So again, Onyx was the stent used in the EBC main study. After stenting from the ostium, first pot, you see here the position of pot balloon. So distal marker exactly in front of carina. And then after pot rewiring and then ballooning with 2.5 by 15 balloon. Stent main vessel without full coverage. So in this case, just slightly longer than polygon of confluence. This is proximal edge of the stent. You see it's not covering until the ostium. And then second pot, 4.5 NC 16 atmospheres. You see again distal marker exactly in front of carina. And the result after distal marker positioning and pot was further improved, rewired through the side branch, kissing balloon sequentially 2, 5, and 3. So the third pot, again with the same position, and the final result with really optimal lesion coverage as well as opening of both ostia of both branches. At 1 year of follow-up, patient alive on full medical therapy. And again, this is his lifestyle, mountain biking twice a week, no angina, no shortness of breath, and no events. What are the pitfalls of Culotte? We presented last year with Gabor Tot a session at EuroPCR, and I'm sharing his nice illustrations. So there are 3 different points during the procedure at which we can discuss potential pitfalls. First one is we do pot 3 times, and each time, of course, position of the pot balloon is crucial, because if we don't do distally enough, we don't open cell in front of the other branch. But if we go too distal, in that case, we shift carina. Second point to make mistake is the rewiring. And this is really after kissing, rewiring through the distal cell that was also very nicely illustrated by OCT, allows you to push with balloon struts from the main vessel stent, and you see scaffold the ostium of the side branch. So making this angulation much more widely open, plus this scaffolding allows you multiple options for protrusion. Sometimes you can stop at the ostium in this kind of configuration without major protrusion, but even if you wish, you can intentionally go with either short tap or you prolong protrusion more just to touch the opposite wall and you do mini culotte. So this is like good, perfect pavement without neocarina. In case that we rewire proximally, you see that with balloon, what we do, we don't scaffold the ostium of the side branch, and in the same time, we push this metal here from the side branch into the main vessel stent. So we create artificially short metallic neocarina protruding into the main branch. That's why special attention and time should be taken when we do pull back and when we rewire metallic neocarina. And the third point that we can make mistake is the kissing. And this is excellent illustration. After stenting towards the side branch, when you inflate the balloon, I will go back again. You see, when you inflate balloon towards the main vessel, what you achieve is that you create this stent deformation at the ostium of the side branch. So after stenting, when you open access to the other branch, you disconnect, you create deformation at the ostium of the stented vessel. In order to correct this, what was recommended by Japanese people, but nicely illustrated by Dr. Gabor Tot, is to do kiss. And with kissing, you correct this deformation before stenting. So when you do kissing, you see when you do kissing, with kissing balloons, you open access, but you also correct this deformation at the ostium. And then when you stent with the second stent, you don't have problem of the coverage. So double kissing makes side branch rewiring more predictable. And I'll share with you his case that he used for illustration. So high syntax score, the key is to show the steps, not the decision making, because decision was surgery, but then because of patient refusal and surgical turn down, patient was sent for plain PCI. And this is distal main vessel, LAD, circumflex. Here, if we enlarge, you can see the lumen contour, and this is the lumen contour according to EBC algorithm that I already presented. Wide angle, no tight lesion at the ostium of the side branch. This patient comes in the low risk of side branch occlusion after main vessel stenting. So decision is to do either culotte, or you can also, in case of expected major risk, you can stent first towards the circ, and by stenting towards the circ, you go in this second arm, inverted provisional, and then inverted culotte. And this is the OCT. So the first step, main branch preparation and stenting, stenting not from the ostium, but from the mid part, from the diseased part of the left main into the LAD. After that, first pot, we disengage, of course, the guiding catheter. After the pot, we rewire the side branch, aiming with the pullback maneuver towards the distal cell. We can use imaging, as it was shown, to document that. Then we do kissing. So this is what makes this procedure double kissing culotte, but it's the same like what we recommended in the EBC main for provisional. So this is actually up to now provisional in the direction of the main branch. After that, we stent the circumflex. This is stenting of the circumflex. Again, disengage the catheter. And then second pot. After each stent, we do pot. Position of the, you see, distal marker at the carina. Rewiring through the distal cell, if possible, of course, into the LAD. And then second kissing, individual, and then simultaneous. And finally, the third pot. So this is baseline, and this is excellent final result in the left main achieved with the double kissing. So what I said, you actually do first provisional towards the LAD, and then you repeat exactly the same steps. You do second provisional with minimal overlap inside the left main towards the circ. So double kissing culotte is actually going provisional in one direction and then going provisional in the other direction. And I will just show you at the end, I just added while watching this case, a tricky two-stent culotte, a case of Adrian Benning as a complication with a nodule, very similar to a case that you presented also. So 80 years old male, risk factors, dual chamber pacemaker, COPD, carotid disease, non-STEMI was clinical presentation, turned down from CABG by the heart team. And this is the baseline angio, and you see this angiographic appearance usually corresponding to nodular calcium presence. So strategies that were discussed are similar as of today. First, is it suitable for EBC main at that time to be randomized? And then what should be done for lesion preparation? Rotablation, both vessels, LAD first or circumflex, imaging if rota is already decided, stent strategy, again, all options possible. If you do provisional layered approach, probably should be stent circumflex first. And this is what was decided. 7.5 French shitless guide radial, rotational atherectomy for lesion preparation in both LAD and the circ, stenting first this tight lesion in the mid LAD, and then doing culotte stenting because patient is randomized to 2 stents. So rota first in the LAD, in the left main, as well as in the mid LAD, then rota towards the circ, then stenting first the mid LAD, and then, stenting mid LAD, and then after that, stenting towards the circ. After that, pot is done, no kissing, just pot, and then second stent LAD, and then pot was repeated, 4.5, and then comes the problem. Wire to circumflex, unable to cross with balloon or any device, microcatheter or tornus, rewired 7 times, repeat pot 3 times, and after several attempts, suboptimal angiographic result was accepted at the end of the procedure you see in this case. So this was the end of the first procedure, and then only 2 weeks after discharge, patient was readmitted again for non-STEMI with ST depression in inferior lateral walls, again neutropenia rise, and again what we see is suboptimal result at the ostium of the circ. Idea was to do OCT towards the LAD to verify adequate position of the LCX wire, and then to try to cross with low profile microcatheter. So first, after confirming distal recrossing, Corsair couldn't cross, and then Caravel couldn't cross as well. So push really hard, but still doesn't cross. So idea was to start with stent ablation with rotational atherectomy. You see first 1.5 millimeter burr, couldn't cross, actually pushed everything out. So 125 finally was able to cross and to create space for going with balloon. 3.5 dilatation with NC balloon at 28 atmospheres with OPN balloon, high pressure balloon was adequate expansion, and then repeated final kissing with both vessels 3.5 by 15 balloons. And this is final angiographic result, much better without adding the third stent. So this is the OCT, and this is the point of a nodule that was actually calcified nodule with central carinal predominance that was the cause for such complexity of this intervention. So it's never the end until you really perform imaging and confirm good expansion and optimal result. So Dr. Davidson, dear colleagues, I would like to repeat again the philosophy of EBC that stenting technique should depend on individual patients' anatomical characteristics, but of course on operator experience, skill, and personal preference. If we plan two-stent technique, this should be done for us in majority of cases using provisional layered stepwise approach, and then decide individually whether to finish with T-tap or culotte as a sequence of provisional. Elective culotte may be considered for long diffuse side branch lesions, high risk of side branch compromise or difficult access, exactly the same as for decay crash. So evidence for decay culotte so far comes from the bench, and we are collecting clinical evidence to document that double kissing culotte has the advantage compared to standard culotte. Thank you very much for your kind attention. I'll be happy to answer your questions now.
Your lecture is so lucid and clear that even the basic interventionalist will be understanding all the concepts very clearly.
Thank you so much.
Sir, as usual, wonderful presentation. But whether it is mandated to do pre-dilatation of both main vessel as well as side branch, because sometimes we may produce dissection and all that sometimes you have to change our strategy. So what is your opinion?
Thank you. Yeah, thank you. Thank you for that question. As I said, it's not part of our routine procedure to perform pre-dilatation of the side branch unless we stent inverted provisional. So we usually pre-dilate the main branch, and then after finishing procedure in the main branch, then we try to cross distally and then pre-dilate and prepare the second branch for the stent. But in case of diffuse disease, like in the first case from EBC2, which I presented, especially if you see calcium, I think it's wiser to do pre-dilatation before, and if there is no clear calcium, I'm not convinced it's really always helpful, but if it's calcific, I think it's much more predictable to pre-dilate and then prepare lesions, see how it opens before starting with the stenting. So not routinely, it's operator discretion, but in case of diffuse disease, especially with large plaque burden in the proximal part of the main vessel, when you expect not only carina shift, but combination of plaque shift and carina shift, I believe it's wise to pre-dilate and remove the, reduce the plaque burden also at the ostium of the side branch.
Can I just ask a question, Dr. Sankuch? In the EBC, you said if in the layered provisional strategy, it's T-tap or culotte. When you do the inverse crush, the neocarina that is reduced, and you don't have a neocarina if you do an inverse crush, but that's taken off in the EBC. Why is that?
It's taken by a decision of the board in discussion. There are just anecdotal cases without series of data published on the inverse crush. But of course, it's possible to do it. According to John Ormiston and bench testing, it ensures full coverage of the ostium of the side branch. But simply, if you look the literature, unless you really see anecdotal cases, you will not find published article with good, serious, and systematic interpretation of the results. So for that specific reason, it's simply expert consensus to remove it from the routine, but doesn't mean that there are some other strategies which could also be accomplished as part of the provision.
But theoretically, that should be a better one than tap, wouldn't it be?
I don't think so. First, for us, whenever you have to crush something, and even for short segment, create 3 layers of metal is not good. So I think with tap, if you do with 2 balloons, every procedure of tap, try to minimize the protrusion and finish with kissing, I'm not convinced that internal crush will give you better result than tap. So I believe most of these reverse techniques provide more or less similar result if you optimally perform final kissing to position metallic neocarina in the center and to try to reduce it as much as possible. Sometimes in narrow angle, it's not possible to reduce. In narrow angle, it has to be a long metallic neocarina.
There are operators in India who do what is called the mini crush technique. So what is the status of mini crush technique? What is your opinion on that? Is it something that should not be done? Or if people have good results and good follow-up, is it a wrong technique to follow?
I can again only express my personal perspective on that one. So mini crush is just one of the steps in the development of the crush stenting. What was the major limitation of mini crush? Mini crush is simply 2 or 3 millimeter without first kissing, 2 or 3 millimeter protrusion of the crushed stenting segment and then stenting the main vessel. So the rate of recrossing and successful final kissing with mini crush was slightly inferior compared to double kiss crush. And this is the main reason. If you are sure that you will finish procedure with kissing, after having kissing comparison, kissing with mini and DK crush should not give you difference in outcome. But if you don't kiss in mini crush, this should probably increase the potential risk for events.
I was talking about that mini crush where there is a final kiss that is accomplished.
If it's accomplished, I don't see any reason to expect difference in clinical outcome. But problem is that the rate depends, of course, from study to study. But with mini crush, for example, in the earlier series, you had only 80% or even less of the final kissing. And this dramatic reduction in the final kiss is probably the reason that people negatively speak about mini crush. Personally, I'm biased because I don't do any of this. So for me, both are not my favorite technique. But I respect people who know how to do it.
Indirectly, in the EBC main, any cases of mini crush?
Only 11 cases in total, 5%.
Okay.
But you know, these numbers are too small. So we have operators in the EBC board who really like DK crush, like Marek Ferenc or Maciej Lesiak, Francesco Burzotta. I mean, we are not a group of copy-paste. We are individuals. So some people like also DK crush in the EBC board.
How much part of the stent you should keep in the main vessel? Because just for doing the pot, you should keep more in the main vessel. Or how can we reduce the metal overlap?
Yeah. You know, for that reason, I think the first stent, whichever direction you go, should go approximately 8 to 10 millimeters. It's difficult to say precisely, but at least 8 millimeters to make sure that you can do good pot. Because having full opening of the first stent really gives you freedom to protrude less with the second stent. If you already do good pot with proximal edge of the first stent fully expanded, then for second stent you need one strut. You need to touch the opposite wall by 1 or 2 struts, so you can reduce as much as you wish.
Why is it that the DK Crush 3 trial not have much of an impact on the EBC physiology? Not physiology, philosophy, sorry.
Philosophy. Yeah, but you know, first we always speak about studies done in the certain region of the world in which there are passionate experts performing DK crush even when they go to bed. They only dream of the steps of DK crush. So when they do DK crush versus something that for them is unfavorable, of course results are different, you know. They are so good in performing DK crush, but I'm not so sure they're so good in performing provisional. And in Europe is exactly the opposite. For us, we dream about T-tap culotte, and when we think of DK crush, we think of some smashed metal inside the coronary artery that philosophically for us is difficult to accept.
Deepak,
with full respect for all of you who know how to do it.
I think it's been an excellent half an hour, and we really enjoyed it, Dr. Stankovic. Thanks a lot.
Thank you so much. I wish you a good day and successful meeting.
Thank you. I think we'll go on to the case, Dr. Natarajan.
Yeah. I think the first case is by Dr. Tom. Dr. Tom?
Yes. Yeah.
So the first case, yeah.
Thank you very much, and warm regards to all of you from the temple town, University town of Manipal and Udupi. Please let me know if you can see my slides.
Yeah, very much.
Yes, Tom.
Thank you. So I will be presenting 3 cases of Culotte bifurcation PCI. Please stop me when my time is up. The first case had angina, TMT done outside was strongly positive, and this is the angiogram. You can see that the LAD diagonal bifurcation is pretty early. They are both fairly sized and quite a narrow angle between the 2 branches. The LAD ostium is and main vessel on the left is having more critical significant disease, and the diagonal on the right is angiographically looking probably not very critically stenosed at the ostium, but away from the ostium there is significant stenosis. So our plan is to have a 2-stent strategy, Culotte, and then we started to wire LAD. And we had to slightly modify our technique because as soon as the LAD was wired, there was slow flow in LAD with the patient developing angina, which was to some extent unexpected because it was just TMT positive and trough was not elevated. So we pre-dilated the LAD and then we proceeded with the diagonal wiring. This is the IVUS of the LAD, and you can see that there is significant amount of plaque burden with some fibrocalcific element as well. And you can see the diagonal ostium here. With some disease but no critical stenosis, and the ostial LAD is again having critical stenosis right from the ostium. So we proceeded with the stenting of the LAD first. From the ostium, we decided to stent because of the large size discrepancy between left main and LAD. The stent was not moving too much. We could position well, and then the flow was good. Then we recrossed to the diagonal side and then pre-dilated the stent struts. This is the IVUS of the diagonal. More fibrocalcific plaque burden on the diagonal than on the LAD. And this is the pre-stenting, pre-LAD stenting IVUS. And then we crossed, dilated, and then stented the LAD to diagonal as well with a 28 mm drug eroding stent. Then we recrossed again on the LAD. We did serial balloon dilatations followed by a kissing balloon dilatation. And this is the angiogram in the end. And this was the post-stenting IVUS that showed fairly good expansion and small amount of not so satisfactory expansion at the LAD ostium. However, the balloon dilatations were with 22 atmosphere balloons, and we decided to accept these results, and this is the bifurcation site image. So slow flow in the LAD during wiring was an unexpected event, which made us slightly modify our technique, as we were wondering whether we should put the first stent from ostial LAD to diagonal or ostial LAD to proper LAD, because almost they both were almost equal size, but the slow flow in LAD made us modify our strategy that the first stent had to go to LAD itself. Second case was an 82-year-old.
Tom,
yes,
can we have some discussion?
Please go ahead. Yeah.
Yeah, the first one, it's you had disease right from the ostium of the LAD, isn't it? So, yes. And when you place the stent, it's almost certainly going to affect the left main.
There was, it is a good suggestion. But when I positioned the stent, I was quite certain that I would be covering it from the ostium because the stent was not moving, probably because of the plaque burden holding the stent pretty tight. So I believed that stenting from ostium would not be difficult for me. And I stented from ostium, and it is confirmed by IVUS that the ostium was well covered exactly on the dot. Even though I agree with you, it is not quite often easy to do that.
The ostium would be covered, but are you concerned about the stent, protruding a little bit into the left main, and that can cause a later on restenosis or?
It is just one strut into the LED left main that I don't think is going to have any significant effect in this particular case. But I fully agree with you. At very often we do a crossover from left main to LED in most of these similar scenarios, so as to have a very comfortable coverage everywhere. I agree with you.
Do you have enough length in the proximal LED for a pot actually before you have the diagonal coming in? There's not much of length in the LED
No,
to get
no,
a pot or anything actually.
there is no enough length to do a pot. So it is almost like a kissing balloon dilatation I had to do. It's almost like V.
It's almost like.
Yeah, Dr. Tom.
Yeah, Dr. Arun has asked. Yeah, because multiple pot is the important step in a culotte. Because in this case, because there is no metal part in to use a culotte in this case, pot in this case. So whether the first sending the diagonal, then second send we are into the left plane. Is it preferable in this case?
No, there is left main is more than I think it's more than 6-7 mm. So I decided to let it be like that because there is no significant disease also in the left main. So I thought I'll just manage LED diagonal just like that. He's pretty young, and let's see from then, from in the future time when he comes back.
Dr. Tom, actually here ostial LED is underexpanded, so it's better actually from mid left main to this one, so that adequate space for part and long term this will be good actually in this case. Actually, if you do like that.
It is not ostial LED that is suboptimal. It is the LED after the takeoff of the diagonal. So whether we send from left main to LED or LED ostium, it is not going to make any difference. And I did a 22 millimeter, atmosphere dilatation, and that's what we could achieve, and we accept it.
I think it's okay for this case, Tom, but but generally, I think when you have this large diagonal arising very close to the proximal ostium of the LED. Now, when we do this, I had multiple experiences where the patients unfortunately do come back with restenosis, which is why I've changed it from left main to LED now, and
I fully agree with you. Most of the times, I also would do a left main to LED stent. This is one of those very rare scenarios where I felt, after long thinking, that from the ostium of LED would be a better option, even though I could not do, there is not enough length to do a pot in the ostium LED before the diagonal takeoff. I showed this case because it is unique.
Sure, great. Okay.
Can I go to the next case?
Sure, next.
Thank you. This is an 82-year-old gentleman who presented with a lateral wall MI. He went a primary PCI to diagonal, and we took him up for interval PCI to LED. This was the first angiogram. You can see that the diagonal stent is very clearly seen, and it is almost like it is stented from the ostium, and the stent may even look like it is 1 millimeter just inside the ostium. So we proceeded to do the LED. We wired, and then suddenly we realized that the IVUS is not crossing the LED, the diagonal ostial position. Then we had a doubt. Then we realized that the diagonal stent is actually protruding a few millimeter inside the LED. So even though it is a staged one, we wired, we serially balloon dilated at the side of the LED where the diagonal was protruding into the LED, serially dilated, then we passed the stent, then we did IVUS, then we did pot, and then we did a non-compliant dilatation. Then we did a kissing balloon dilatation and a sequential balloon dilatation. And then this is how it looked in the end. So this is more like a staged procedure where we it was unexpected for us because we never thought the diagonal stent was actually projecting into the LED. But because the IVUS catheter did not go, we had to dilate serially with smaller, later on larger balloons, and then pass the stent, then do the side wiring, non-compliant dilation, sequential, and then kissing balloon, and then get a good result.
So it is a mini crush that you have done, isn't it?
It is not. The wire in the LED went through the middle of the diagonal stent a few millimeters. So it becomes not mini crush. the wire went through the middle of the stent.
Sorry, I couldn't understand. You stented the diagonal again?
No.
No, no. It's not mini crush. It's something like a provisional.
It is staged culotte.
Yeah, it's staged culotte. Yeah.
You don't have much overlap into the main vessel actually to call it
No,
a culotte.
it was unexpected. It is just 2-3. It is less than 5 mm or inside the LAD, which was probably unexpected even for the previous diagonal PCI operator as well, because I think he was planning to stent either from just inside the ostium or at the ostium.
Do you have any imaging on how the crush looked on the ostium of the diagonal? Because finally the ostium of the diagonal, we're not very sure whether it's...
This IVUS image, I could not, I didn't get it, so I'm very sorry.
Fluoroscopically, there is some gap. We can see that.
Fluoroscopically, it looks like this diagonal like that. Inside the diagonal. Yeah. There is no way it is projecting into LED. But the surprising part was when we were passing the IVUS catheter into the LED, it was hitching at the diagonal takeoff. That is when we realized that something awkward is there.
So whatever little part of the diagonal was into the LED was changed into a culotte.
Yes. Because our main objective of the culotte to just get the proper metal overlap, to get the whole metal coverage.
Few millimeters only was there in this particular case.
Right. Shall I have the third case in?
Sure. This is a 70-year-old male who presented with non-ST elevation MI. This was the angiogram. You can see that the diagonal ostium is occluded, and you can see the narrow angle between the deceased LAD and the occluded diagonal. We could not wire the diagonal easily. We had to wire with a fielder, with a microcatheter, and then exchange it with Sion and then balloon dilate so as to establish antegrade flow in the diagonal. And then we could not see the distal diagonal because of slow flow in the diagonal. So we medicated and the patient started to become restless and have some angina. We thought the LAD also was becoming a little bit tricky. So we positioned the stand, but we thought that because of the narrow angle and there is a risk of diagonal ostium mismatch, even though I positioned the balloon inside the LAD, I decided that the patient being restless and having frequent long breathing movements, the stent may move a little more than expected. So I decided to do a culotte in this case, and I pulled back the stent a little more favorably into the LAD to make sure that the diagonal flows very well, and then tackle LAD. So I tried to position a few times, and then I pulled back the stent, and then we stented the diagonal with 2.75 24 DES. After stenting the diagonal, the patient became relatively stable, but then we realized that there is a dissection at the stent edge, the diagonal stent edge, which is not a comfortable news for the operator, of course. We waited a few minutes to see whether there will be any abrupt closure or not. We were deciding whether we should do a balloon dilatation or drug-eluting balloon or yet another stent to make sure the diagonal was safe before we moved into LAD. In the end, we decided to stent the LAD because the patient started to become restless, having chest pain despite a flow in diagonal. So we stented the LAD quickly, and then after the 48 millimeter drug-eluting stent, we observed for the diagonal flow. We could see again the probable dissection in the distal stent edge of the diagonal, but the flow in the diagonal is maintained. So in the end, we decided to do a balloon dilatation of the distal stent edge with a 2 into 15 mm balloon. And then we did a sequential followed by kissing dilatation of the LAD diagonal ostium. And then we watched a few more minutes to see if the diagonal is having any problems. The diagonal continued to flow and the patient became quite steady and stable. So this was the final angiogram, and we decided to accept this result in the distal diffusely diseased diagonal with good flow in LAD and re-establishment of flow in diagonal with patient being completely symptom-free.
Did you do
This is the
port?
final result. Yeah, final port is done. Yeah. This is the end result of the angiogram. You can still see that there is the dissection, the non-occlusive dissection seen at the distal stent edge of the diagonal, but we decided to leave it like that. So take-home messages, Culotte technique can have potential complications like distal stent edge dissection of side branch or main vessel. Unexpected unstable plaque in main vessel or side branch can cause abrupt closure or slow flow in main vessel. Modifying the sequence of stenting and the bifurcation technique may be needed based on clinical scenario on a case-to-case basis. So any discussion points, please?
This is not a Culotte, isn't it? It is a crush technique.
No, I wanted to do a mini crush, but because patient was breathing deeply, I decided to change my strategy. And
you put a stent into the diagonal and then you stented the LAD. So there's no Culotte there.
No, I pulled back the balloon and the wire.
The LAD. He had substantially pulled the stent into the.
I pulled the stent back into the LAD. Correct. Yeah. So I had to change my strategy. I pulled back the stent into the LAD. So I did not crush the diagonal stent. I pulled back the wire and the balloon from the LAD back again. Then I went in back through the stent struts into the LAD, rewired.
Oh, I see. Okay.
Yeah, that is basically we had to change our strategy.
Yeah, at the time of stenting, you change your strategy.
Correct, correct.
It's inverted Culotte.
But Tom, when you didn't see the diagonal, you said stented the diagonal because there's no flow in the diagonal and you couldn't see the distal vessel, isn't it?
Diagonal was totally occluded from the beginning.
Yeah. So in which case, 2.75 probably
I
was
can
an
see
oversight.
Probably, yeah.
We'll have to. Into the main vessel?
Less than 10 mm.
So do you think the size difference between the LAD and diagonal is significantly different to take up Culotte in this case?
What other option do I have with this narrow angle and me having a chance to miss the ostium if I try a mini crush? Then I would be ending up with yet another stent. So I thought I'll just.
DK would have been good here, isn't it? DK crush, because you didn't want a closure of the side branch.
Yeah, yeah. It is if you have a lot of time and good size vessel, DK crush is always quite comfortable to do. But once you have a stent inside and patient starts to get restless in acute MI, it is not always that you will be able to execute the strategy you would like to do in a 2-stent strategy.
Yeah, but in this case, the vessel size is totally. The diagonal is a smaller and the LAD is bigger vessel. So Culotte may not be the ideal, but.
With the narrow angle, what choice do we have?
Always the
when the patient breathes fast and deep, you don't want to miss the ostium. There is a distal diffuse disease even in the landing zone and distal to it. So it is going to be a never-ending chase trying to get the near normal zone. We don't get the ideal patient, as we all know.
But what I believe that in acute situation, what you did is absolutely fine. I mean, you can see that it's a non-flow limiting dissection. Your diagonal is flowing well, and you have achieved a reasonable result then probably in acute situation. I mean, we have to balance both the things. At times, we always keep on saying that better is enemy of good in cath lab. So whenever you try to achieve more than ideal results, then you are stuck up with something which you may repent later on.
Yeah. And it was a totally occluded vessel. So once I have established antegrade flow and non-occlusive dissection in not a major territory, I can accept it. I think all of us will accept it.
Yes.
Sometimes we have to change our strategy based on the patient condition also.
Yeah.
Right. Shall we go on to the next? Natarajan, it's all yours.
Thank you.
Are you able to see my slides?
Yes, Natarajan.
Thank you. So Actually, I had some difficulty in pulling up some previous slides, so I had just quickly made this presentation. I'll use this opportunity to just revise most of the points that have already been stressed, especially for the younger group that has logged in for this program. I'll just go through the few anatomical considerations in bifurcation disease, a few basic strategy concepts in bifurcation, where we end up using two stents, either a second stent in a provisional strategy or an upfront two-stent strategy. I'll just discuss a prototype case example for Culotte stenting, and I will also stress upon the advantages and disadvantages of Culotte stenting, the challenges in Culotte stenting, and ways to counter the challenges, which actually the previous speaker has nicely shown. I'll just touch upon it once again. Bifurcation, by definition, is stenosis or diseasing involving the main vessel and a side branch, which is more than 1.5 millimeter, arising within the diseased segment of the main vessel, with diseased ostium and proximal segment extending beyond 5 millimeters. And the frequency of bifurcation stenting that we see in our practice is as close to 6 to 20%. The classification schemes are based on two features. One, the location of the plaque burden in the main vessel before the bifurcation, and involvement of the side branches after the main vessel proximity. And the angulation, the distal angulation between the distal main vessel and the side branch. These are the various classification systems. We won't go into the details. And this is the most often quoted Medina classification. And if you look at these two types, which are some of the most difficult ones among bifurcation, extensive plaque burden before as well as distal to the main branch proximity. So one vessel, two stents. In the first session itself, we have discussed this. There is no controversy. In most bifurcation lesions, one stent is the treatment of choice. In a provisional stent strategy, elective stenting of the side branch after the provisional stent strategy depends on the angle. If the angle is more than 70, TAP or one of its T or one of the modifications, and if the angle is less than 70, you can have Culotte stenting or reverse crush technique. Indications for elective two-stent strategy is true bifurcation, significant disease of the side branch, major plaque burden, side branch of adequate size, large territory of supply, side branch disease extending beyond 5 millimeters from the ostium, and challenging access to the side branch. Re-access may be virtually impossible with severe, very bad angulations, calcification, and acute bends. So these are the situations wherein one may have to choose an upfront elective two-stent strategy and not the provisional stent strategy. And not to forget left main bifurcation and circumflex disease. The two-stent techniques, it depends on the anatomy and the complexity and the indications, crush and its variations, T-stent and its variations, Culotte stenting, V-stenting, and the not very popular in today's time, simultaneous KISS stenting or the Y-stenting strategy. We will, for the purpose of this discussion, restrict to Culotte stenting. This is a stepwise approach to bifurcation disease. We will answer the following questions. Side branch needs to be preserved. If the answer is no, it is only main vessel stenting. If the answer is yes, the side branch needs to be preserved, the next question to answer is the likelihood of side branch occlusion high or low? If the likelihood of side branch occlusion is low, you can go to a provisional strategy. If the likelihood of side branch occlusion is high, you should resort to a two-stent strategy. And the angle between the distal main branch and the side branch dictates the method in which we do the two-stent strategy. T-stent or TAP when the angle is more, and if the angle is less, DK crush or Culotte is the way to go about. The ideal anatomy for Culotte stenting is a roomy main vessel, near identical sizes of both branches, minimal size mismatch between the main vessel and the branches, less than 70-degree angle between the branches. So these are the important anatomical determinants before we embark on a Culotte stenting strategy. With this background, we'll go through a case. A 67-year-old male, hypertensive, single vessel disease, underwent a PTCS stent to LAD in the February of 2004, long back. And we stented the LAD. And this was a provisional single stent strategy and the flow was good. And for 14 long years, this patient was doing well. He developed effort dyspnea in the May of 2018 and the TMT was very strongly positive and he had an angiogram in the May of 2018. You can see that there is significant osteal disease of the LAD and a 50 to 60% osteal disease of a dominant circumflex. The left main is roomy and it does not have much of a disease. It's a Medina 011 kind of a bifurcation disease. And the previous stent is patent. The mid-LED stent is patent. And this is the caudal shot showing the tight ostial disease and the borderline circumflex ostial disease. And the RCA was non-dominant here. So here is a patient who has an ostial LED 80% stenosis, a dominant circumflex with a 50 to 60% ostial stenosis, as you can see in this frozen image, a 3.5 millimeter circumflex, Medina 011, bifurcation angle 70 degrees, roomy left main and nearly equal and good sized LAD and diagonal, LAD and circumflex. And he was taken up for a PCI. And we chose a Culotte technique for the reasons that we have already discussed. And the various steps in Culotte has already been discussed in great detail during the course of this session. To save time, I will skip this slide. So both the LAD and the circumflex were wired. The LAD was dilated with a 3 millimeter balloon. And you can see that there is an ugly dissection at the ostium of the LAD here. And this patient became a little symptomatic, the way Dr. Tom was telling in his third case. The patient had significant angina. Though the flow was good, the patient had significant angina. We initially wanted to stent from the left main to the circumflex. Because he was having angina, we had to change the strategy during the course of this case. Then we dilated the circumflex ostium. And we stented from the left main to the LAD with reasonable protrusion into the LAD, as you can see here, to allow a meaningful pot. And we deployed the stent. And we did a pot at this stage. The pot is very crucial after the first stent. The need for multiple pots was amply stressed in the previous talks. The importance of the pot is to have a better apposition, to open the struts well, to prevent the second stent. It prevents the second wire from passing abluminally and allows easy wiring of the other vessel, circumflex in this case. That is the importance of the first pot. And we wired the circumflex. We made sure that we are not abluminal by stent boost images. And we dilated with a smaller balloon. And this is the stent from the left main into the circumflex being deployed. And that is the result at that point. And then the next pot is very important, again for the reason of improving apposition and preventing abluminal passage of the wire into the LAD in this case. The first stented vessel, you don't want an abluminal passage. So that is the importance of the second pot. And then we ended up with a kissing balloon inflation. This is to show that how nicely the ostium of the LAD and the circumflex have been achieved in this process. And then a final pot, and then with a 5 millimeter balloon in the LAD. And that is the final result. So Culotte stenting, what are the advantages? Complete ostial coverage of the side branch and the distal main branch. There is no plaque or shift or carenal shift. And easy future access to both the vessels. The disadvantages are multiple wire exchanges, kissing balloon inflations, need for bigger catheter. So what are the challenges with Culotte stenting? Side branch stent, if it is small, it causes gross malapposition in the proximal main vessel. Difficulty taking a stent into the angulated side branch. Difficulty taking a second stent across the first stent stents into the second vessel. Having 2 layers of stents in the main vessel. Not having sufficient stent length in the main vessel for a meaningful pot. With 2 layers of stents in the main vessel, inadequate stent apposition can result in stent thrombosis. So how do we circumvent these challenges? Side branch stent causing gross malapposition in the proximal main vessel. Choosing the right case with minimal size mismatch between the side branch and the proximal main branch is an important requisite for selecting Culotte as a strategy in bifurcation stenting. Difficulty taking a stent into the angulating side branch, adequate pre-dilatation and stenting the angulated side branch first. In this case, we had to make a reverse because of the dissection in the ostial left LAD and the patient becoming symptomatic. Difficulty taking a second stent across the first stent into the second vessel to be stented. Adequate opening of struts across the ostium of the second vessel is the way to go. Having double layer of stents in the main vessel minimized length of one of the two main branch stents, as was shown in Dr. Vijay Kumar's case in the first. Not having sufficient stent length in the main vessel for pot, ensure stent length in the main branch longer than the pot balloon available in the shelf. With 2 layers of stents in the main vessel, inadequate stent deposition can result in stent thrombosis. Adequate sizing of the pot balloon to match the main branch size, preferably by imaging guidance, will circumvent this challenge. Inadvertent wire passage between the stent and the vessel during wiring can be prevented by adequate pot at every stage. So in conclusion, PCI in bifurcation lesions can be a challenging exercise. The anatomy has to be well understood to devise an appropriate strategy with regards to size of the 2 side branches, as well as the distal angle between the distal main vessel and the side branch. Angulation of side branch, involvement of side branch in the disease process, size of the side branch related to the main vessel are points of importance. However attractive the acute results may be with 2 stent strategy, we all know that the long-term outcome is better with a single stent strategy. One should have a high threshold to stent the side branch. However, when it is absolutely essential to resort to 2 stents in a given case, either before or after the main vessel stenting, depending on the anatomy or progress of the events during the procedure. The second stent strategy varies according to the anatomy. The Culotte stent, as was shown in this case example, is a handy 2 stent strategy both in provisional stenting as well as upfront 2 stent strategy in selected cases. Thank you.
That is nice, Dr. Natarajan. You explained all the steps of the Culotte stenting and with a nice example. Any questions or any queries from any of the panelists?
Natarajan sir, very nice demonstration of Culotte. This is a perfect case for Culotte because both equal size vessel. But if your left main is short left main, and so we are going for Culotte, but we cannot do the pot because in this case also I think we have gone beyond that carina. So what will you do? Because the left main is very short.
You should extend it to the ostium. You should extend it to the ostium. Thereby you will not have a pot in an area which is unstented. Maybe there may be a little balloon overhang in the aorta, which does not matter. It is prudent not to actually do a pot in an unstented area. Yeah. Rather, it is good to have a little bit of the stent overhanging into the aorta. So you can.
But this distal part of the balloon should be at the carina.
Yeah. The one which I said as a pot is actually not a pot. The pot was actually done at the level of the carina without encroaching into the LED.
Very nice presentation, Dr. Natarajan. The case, actually, this was the ideal case for Culotte, and almost equal size of arteries, and you shown very nicely how to do Culotte for the young people who are doing it. I would say that probably we all are acquainted with almost all the techniques of bifurcations, and by case-to-case basis, I mean, every case is a different case. So probably you decide on which case, which technique you want to go, but the classification or the roadmap which you suggested, that is absolutely fine. I mean, for a beginner, if the angle is narrow, then probably Culotte is a better choice. If you have a wide angle, then probably you can go for a T-stenting or a tap. Or I don't know why people don't like in bifurcation club about the mini crush. We people are very much comfortable with mini crush. I mean, I've been doing a lot of cases with mini crush, with reverse crush, and I would say that this is very, very handy step. And when you are limited with your hardware, I mean, repeated balloons, repeated wiring, in those situations, probably mini crush and reverse crush is a very, very good and handy technique with good long-term results. And what do you say, Dr. Tom? And
we do a substantial number of mini crush.
Yeah, same here.
In our institution, and the chances of not doing a final kiss is almost negligible.
Yes,
we almost
fully agree.
End with 100% kissing inflations.
Fully agree.
What is the worldwide failure to do a final kiss in a DK crush technique, Dr. Deepak? What is the worldwide statistics? Is it
So
always?
if you look at the statistics, it's around 99%. It's not 100%.
I would say that the same applies to even mini crush technique. Though
no, I think Nathan, this is what I asked Dr. Stankovic here. You know, the inverse crush and internal crush and the mini crush are essentially the same, because they have taken it off from the EBC because of this. Because they said, you know, in few anecdotal cases there have been increased incidence of you know, stent thrombosis and deaths.
What did you mean by inverted crush when you asked that question to Stankovic, Madhu?
It's the same thing, Narajan. See, when you're the mini crush, the same. The first you put a like the tab instead of the carina, the long thing coming in, that is crushed. What do you call the mini crush? The same thing.
Okay.
But in the EBC language, they call it the inverted crush. That's the only thing.
The reverse crush is a technique used for bailout.
Side branch.
For bailout. When you let us say you do a stenting of the LAD. In the process, you had a dissection in the diagonal. So you take a second stent, and the angle is less than 70. You take a second stent into the diagonal with minimal protrusion, crush it with a balloon in the LAD. So the crushed stent will be actually within the LAD, it will be in the lumen of the LAD. That's what differentiates between reverse versus classic crush. Correct me if I'm wrong.
That is internal crush. Internal crush or reverse crush, that is called.
That's what I
thought. Is external crush. Mini crush is external crush for side branch. But here you do provisional, then why protrude into the lumen, that is called internal crush or reverse crush.
That's why I got confused by Dr. Martin's question.
The first in the mini crush is first you have the stent and you crush it. Here, first you have the main stent. It's the sequence of events.
Just a matter
my question is
just a matter of semantics.
So my question is, why would somebody want to do that? Reverse crush. You can just straight away stop with doing a tap, isn't it? Rather than making the things more complicated.
What if the angle is 45 degrees? What if the angle is 45 degrees?
The
angle between the distal LAD and the diagonal is only 45 degrees. What will be your approach?
Still, you have a carina, and with maybe one or two struts protruding across the carina into the main vessel. So that is the only disadvantage. There are two disadvantages when you decide on a reverse crush. Probably one, you make it more complicated, multiple again recrossing, crushing and all. Second thing is you have more metal. You're crushing more metal inside the stented vessel.
What would you do in your practice when there is a need to stent the diagonal?
Tap.
But the diagonal LAD angle is only 40 degrees. What will you do?
So still a tap, hoping that only little bit of metal is protruding.
When the angle is less, Deepak, it is not less. It has to be a significant amount of the carina. So this is what Dr. Gorin was also saying. When you're crushing the can, so there is as little metal as possible in the carina, but still there's a neo carina. But when you have a narrow ankle, you have so much of stent coming in. That will be the flow divider. You'll have metal there, and you never know what's going to happen long term.
Not only that, if there's a need for a second procedure, let's say 6 months down the line, if you were the primary operator, you know where the neo carina is.
You would know.
So probably you'll keep the angle of the wire on the other side of the vessel, not to actually come near the neo carina. But an operator who does in a different center may actually go and poke into the neo carina that you created out of because he doesn't have the experience of doing that particular case.
Like you would know what you've done, Natarajan. I mean, you're just trying to be nice, but essentially it's this way. I mean, you can have the wire going whichever way. You can have the wire going straight, but you can have the wire going into the diagonal and then coming back into the LAD, and that will distort the whole thing.
Yes.
You never know what's going to happen in the middle. So which is why tap is generally going out of favor in many places, many parts. And if you talk to Dr. Chen, I mean, he would say, I never do. If you think there is something, you just do a decay. But that is the other extreme of the thing. But the problem with the provisional is what will you do when you need a second stent? That is always a dilemma.
Dr. Madhu and Dr. Natarajan, basically the European operators prefer the provisional T-tap, T or Culotte. But Asian Pacific operators mainly prefer DK crush or mini crush, whatever the thing.
The Asian operators prefer the
Asian Pacific operators, sorry.
Maybe because of the economic reasons. The need for multiple new balloons, etc., may be playing in the mind of operators for example, in our country. where instead of DK crush, they may be doing a mini crush technique.
Mini crush. Yeah.
Unless you deal with very affording patients like how my good friend Deepak has.
Yeah, as Nathan sir has rightly pointed out, this is a technique where we can use both in provisional as well as electrical sensor. My simple question is, what is inverted culotte? What is the difference? Because if you are stenting the side branch first, it is inverted culotte.
Yes, exactly.
Exactly.
So main, if the side branch means inverted culotte, it becomes.
And if you are
like
sending to the
inverted provision like.
Yes, if you are sending the main branch, it is a culotte.
Yes.
And the double kiss culotte is you have one intervening step of doing a culotte by doing a kiss.
Kiss. That's a new one. That's a new thing which they say would be equivalent to a DK crush.
But that we have been anyway doing most of the cases of culotte stenting. We do that kissing step without even knowing that there is a strategy called DK culotte.
Yes, sir. They made two modifications. They made two modifications. One, they made the protrusion from the side branch less than 5 millimeters. So that they call it as mini culotte, and then an extra kiss. Once you have the stent coming from the diagonal into LAD, you recross into the LAD, and then you do a kissing balloon dilatation before you put in the second set. So these two modifications are made, and they have made out that with micro CT studies and the fluid dynamic studies, the position of the stent and the bifurcation is better than the regular culotte technique, but we do not have clinical data.
Yes.
On a lighter note, I feel that the Europeans take pride in saying we kiss, we don't crush, compared to people in the other continents. As Dr. Natarajan said, it is a change, it's a difference of attitude or philosophy.
But unless you have a crush, how can you kiss, Tom?
That we'll ask Dr. Goran.
You crush while you kiss.
It's the sophistication of Europeans.
Shall we go on to the next ceremony?
Yeah.
So we'll have lots of pictures in OCTs, all your ceremony.
Yeah, good evening. Can you see my screen?
Yes.
Yes, okay. Thank you, Deepak, for organizing such a good meet. All 3 days has been excellent. And a week back, Deepak called me and he said, you want to show us some complex bifurcation cases. So on that, probably what I could do is I have few cases we will discuss, and probably I'll try to show some 2 or 3 cases or 4 cases, and we'll have a good discussion there. So generally,
culotte has 165 slides.
no. Actually, this has all complex single stent, and then so I'll just stick on to culotte, something like culotte. Okay. It is going to take probably 12 to 13 minutes talk. Okay. So this culotte stenting, basically we can use it for elective 2 stents or a bailout strategy, as we have all been talking, and modification of culotte, like we have a dedicated bifurcation branch stent, and of course many techniques like mini culotte, nano culotte. So these are some of the culottes that we have. And the problems, I think KU Natarajan sir has clearly told all these problems, which I will not go in detail, and probably we will look into some solutions when we see the cases. So look at this patient. Actually, this patient, he had a significant angina, and we were trying to do a LAD stent here. And we initially did not plan for any imaging in this case due to some financial reasons. And then this is the stenting which I have done, then placed this LAD stent there. And when you see this LAD stent getting placed there, just near the ostium, but usually most of the time we try to cross over from the LAD, from the left main into the LAD. But this was a case like we did not wanted to do much in the left main and wanted to finish with a single stent. So just landed it there. So this is the stent being placed in the LAD there. And once you do that, once I deployed that, you look at this circumflex lesion, what has happened here. So this is what happened. So now there's no other way now. So I did a OCT there for this patient to look at what is happening there. So when you look at the OCT here, you see that the LAD stent is extended. It's quite common, like it can extend beyond, and then there is impinging on the point of confluence there. and it has come to the ostium of the circumflex. So this OCT, you see, this is the ostium there, ostium of the LAD, and we will not discuss all of the routine findings. We'll just concentrate on the bifurcation. On the anterior issue, see that there was something protruding inside the lumen. So that was a tissue prolapse there. And there was a dissection there in the LAD extending into the circumflex. There was a dissection point there. And then there's a tissue prolapse there now. And now this is the distal left main stretch there. So there is a stretch here, and opposite to that, there is no stretch here in the left
when you have
main
dissection,
there.
do you say tissue prolapse, Mani?
Yeah, there is a dissection and something protruding here. See, this is,
that
there was a
dissection.
dissection. Yeah. See, this is a dissection which is gone there. And when there is some protrusion also beyond the dissection. So I think that's why I called it, but you can take it in anyway. Anyway, when you see the other images, you will appreciate it. So, but the reason why I did it is even after stenting, this was persisting. So I think looking at all those things, I've labeled it like that. And this is the distal left main, and this is of course the left main now. So now, what options do we have now? Generally, you can, there's a stent here, and there's a very critical LCX disease here. So you can crush the stent there, or you can do something like a reverse T, or you can do something like a culotte here. So in this case, what happened is, so I tried to cross a wire inside the circumflex. So initially, actually, I wanted to do something like a culotte or a crush. But anyhow, I was not so sure about the crush and the extension there. So this is what has happened. When you look at the stent boost, there is a wire going like this, and this position is excellent for a crush there. You can put a balloon, crush it, and then recross and do it. But I tried to rewire, and then this is what I have achieved here. So I went into the protruding thread there, and then went into the circumflex and dilated through the stretch there. So this is what has happened now. It is something you can call it as mini culotte or a nano culotte. There's a LAD stent which has come to the distal left main, and there is a circumflex stent which is also in the left main there, and then did it like this. And luckily for this is almost the circumflex vessel was not too small. So in such case, probably we should have done something like a crush or two. But here, I could manage the adequate size stent there and deployed there. And post stenting, you look at this OCT here. See, this is why I said even after stenting, there is something protruding there in that area. So that is why we did it, called it like that. And this is the circumflex ostium. And then these are the overlap stents. You can see the two layers of the stents there. And then you come back, and this is again a LAD stent and the circumflex stents getting overlapped there. And there is a live thing going on here at the left main junction now. And again, finally did a kissing there and did a final pot there. And we could achieve a good bifurcation point there, a figure of 8 with excellent opposition and good flow. And the patient was very stable. And this is almost a quite old case now, and he is on regular follow-up, clinically doing well. So nowadays, what I do is, but I don't know how many of you will accept, this is one of the recent cases, which I showed.
Ceremony, can we have some discussion after each case? So, we can.
Oh, definitely. No, what we can do is you just see this case also, something similar, and then we can discuss it.
Right.
So this is a recent case here. And see, he had an infraposterior MI, pulmonary edema. He was thrombolized and just landed in our hospital. And this is the angiogram here. This is the culprit was a dominant circ having a thrombotic critical stenosis. And there is something in the LAD also, that tight stenosis in the LAD. So actually here, this is the LAD lesion there. Wanted to stent off the circumflex because it was an acute MI and had pulmonary edema, just recovered from pulmonary edema. So placed the stent and deployed. Same thing happened. Probably the stent got extended here. You can see that the circumflex stent has come back into the left main now. So it is there now, and then I had to do what I had to Initially, I was planning only to treat the culprit circumflex. I had an idea of treating LAD electively some other time. But now, after stenting this, the stent has come back into the left main. And I don't want to just leave it off now, because if I take out that wire from the circ, again rewiring, we are not very sure. So I just wanted to go ahead and treat the LAD and the left main also at this time of point, this situation itself. So OCT showed that there is a clear-cut protrusion of the circumflex into the left main now. But when you see this is the circumflex stent inside the left main extending there. And now, again, a similar thing could have been done. But what I did is I tried to pass a wire from the LAD into the, from the left main into the LAD. The balloon was clearly crossing there. So there was no resistance there. So probably we could have dilated it and crushed it. But off late, what I am doing is, because if you crush it, as Deepak was saying, you are going to have more steps there. Probably you will have to do recross and then again do 2-3 OCTs, make confirmation. In such a patient who is just recovered from a pulmonary edema, acute infraposterior, and a dominant circumflex vessel there. And you are treating the LAD, which is a non-culprit, including the left main. So I just wanted to simplify, but we have few cases like this. I just dilated the LAD. I did not do anything to the circumflex of the left main. And then what I did is I kept a stent from the LAD into the left main and then deployed there and recrossed, just recrossed into the circumflex there and just did a kissing and then did a pot and came out with the good results. So why this, we call it as something like a reverse T, because I came across a paper and after that I have done few cases where in comparison with even DK crush or whatever technique, when you use this reverse T and protrusion, you get a better results, or it has been shown that it is slightly superior to DK crush also. But it's a very small paper which has been published recently in November 2021. And my experience is also showing it to be quite good with this technique. And even electively, we are doing some cases of reverse T and protrusion. And we have a OCT follow probably, which we can discuss it in some other meetings now. So Madhu, now if you want to discuss, you can discuss. Next, we'll go to the different case.
Can you explain what is this reverse T and protrusion? Can you explain?
Yeah, it is. See, it is something like this. See, for example, what happened in this case is, okay, I'll do one thing. Just wait here. Hold on. I will just try to show you that what it is.
Hello.
This is crushing, isn't it? Mr. Mani?
Yeah, it is some. It is not crushing. You are not crushing. See, for example, look at this case, which I have. It is actually not a culotte. So when you see this case like this, what we do here is, so initially we dilate both the vessels, and then you keep the first stent in the circumflex like this with slight protrusion and deploy it. Don't crush it, don't do anything. And then you take a stent, one more stent into the LAD, dilate it there, go to the LAD, and then deploy. And you get excellent results, but any of long-term results are awaited. And there is no need for, again, recross, and there is no need that you will not lose the side branch at all. So that is one of the easiest way of doing this bifurcation, but anyhow, it requires evaluation further. So when you look at this, see, this is what is the bifurcation you get. Previously, what we used to think is, if you do like this, you may not cover the ostium of the side branch. But here, on imaging, we can document if the angle is good, you get ostial coverage of both the branches. So
this is the mini crush, isn't it? What Natarajan is talking all along.
It is. Sellomani,
Yes.
If you also had a stent from the undeployed stent from the left main to the LAD at this point, this is exactly what we do in the mini crush technique.
It is something like that, but a little bit of modification.
What way?
Modification? You will remove all the wires, and then you again do a big crush there in the mini crush, But here that step is not there.
But what I believe that if you are keeping both the stents together, if you have planned for the two stent technique, it would be like it will make your life so easy that you keep both the stents together, one from left main to LED, another is in LCX, slightly protruding into the left main, and then you deploy the L6 stent first, take out the wire, and then you deploy the LED, then recross it, and then do kissing.
Right. So, in the first case, when you stent it from the circ to the left main, the size discrepancy, was it a concern for the stent, overexpansion of the stent?
Yeah, of course, the circumflex was not so small, so we could expand the left main up to the 4. So, so that was not a big issue because we put a 3 size stent, a 3.5 stent in the circ and then expanded.
But to just understand the first case, when you have the thing on the OCT, do you call it thrombus or tissue prolapse? Where is the tissue? Where is the structure prolapsing? The circ earlier was disease-free. So after the LM12, after the initial stent, you had something in the ostium of circ. So we would call it thrombus or just to understand actually.
No, that was actually when we dilated the LAD and stented the LAD at the distal left main. Probably there was a dissection and then there was something protruding, probably that we called it as tissue prolapse. And why we did is even after stenting, it was seen behind the stent, but the stent expansion and the area was very good there. It could be, but it was not looking like a thrombus. It was not definitely a thrombus.
In this case, Selamani, because for getting the wire into the circumflex, I mean, you wanted it not to be a crush. So in which case you could take a bigger balloon and do something like a pot so that at least you expand the stent in the LED to left main and then wire it. Would that be easier?
Yeah, I think that will be a still better idea. So where you can put a bigger balloon, dilate, and then, because here in this case, there was a dissection and almost very critical narrowing in the left LCX ostium. I did not want to lose that circumflex.
Scared of you.
It was a flowing vessel.
But many a times in the pure ostial stenting, you find that you're never at the ostium. You always have many struts into the LMCA. And after a so-called attempted pure ostial stenting on the imaging, you find struts into LMCA. After seeing all this, do you intervene? If the patient is symptom-free, the other vessel is flowing, your pure ostial coverage was not there. You have struts overhanging documented on the imaging after your attempted ostial stenting. What would you do?
So many times what we do is, we try to do a pot-like procedure there. If there is a significant amount of struts into the left main hanging there, take a bigger balloon and dilate, that is more ideal. But if it's a very short segment, like 1 or 2 struts, I think we cannot do anything. We can just leave it level.
If it's a bit too much, Arun, what you're saying, that happens quite a lot. So what if you, like on the stent boost, you find that it's coming into the bifurcation, then what I do is I keep a bigger balloon, as Selamani was saying, keep it with the stent boost and make sure that it's within the stent and dilate it, and possibly get another wire into the side branch and do a kissing balloon all the time, making sure that both remain within the stent. It's not ideal, but that's probably the best that you can do if it happens.
Because there's going to be a lot of size mismatch between LED and LMCA to get a good dilation.
Yeah, but this is error in judgment which has happened, isn't it? So you have to make the best of what has happened.
Yeah.
A bigger balloon at a softer pressures.
Yes.
Is there any data which says that we need to intervene in all these things? Because pure ostial stenting before imaging was being tried for many years. Every patient doesn't come back actually, even if you have some struts overhanging in LMCA. Like with imaging, we are more and more realized it. But is there any data telling us that we should intervene?
No, it's just anecdotal. I mean, when you have many patients coming back, then you try and do something. So no data as such. I don't think anyone would have data.
No, I fully agree with what Dr. Arun is trying to say. In an ostial LED lesion, if you should ideally have 1 or 2 struts in the left main. If you do not have 1 or 2 struts in the left main, that means you have missed the ostium of the LED. So he's absolutely right in saying that 1 or 2 struts will be in the...
No, Natarajan, the question is that 1 or 2 becomes 3 or 4. Then what do you do? That is the question.
If it becomes 3, 4, 5, 6, 7, 8, then...
That is a problem.
Then it becomes left main to LED stenting.
No. See, the basic is, it is, if you can oppose the struts, that is good.
Yes.
So if you can do it, do it. If you cannot do it because of number of struts are less, or probably you cannot expand the stent to that size for some reason, then you can leave it. Nothing happens. But if it's a large amount of stent hanging there in the left main, you can still go ahead and dilate. Then if you don't do it, I think it is not acceptable. If possible, you should do it. Always, opposed struts are better than hanging struts.
Yes.
Correct. Silvamani. Correct. Correct point. Go to the
next case.
We'll go to the next case.
Yeah.
Okay. So this is one of the branch studies which I was doing some time back, where what happened is dedicated bifurcation stent and treating the circumflex OM1 and LED there. So what we did, we stented that. And then after that, I was trying to rewire the branch, and then I wanted to do an NC there. So what happened, it was very difficult to take that wire inside there. So in this, what you could see in this OCT image is very difficult to cross with a balloon because after stenting, it was rewired. Wire had come out and then we have put a wire there. So when you look at this interpretation, so there are some struts, some wire behind one strut here. And then this is the branch where the wire has entered. And then there are here certain areas where you are not seeing the second wire at all. So when you interpret this, see actually this green line is the area where you are getting this cross section. At this point, you can see a wire behind the struts there. And in between here, you are not seeing anything. Probably is it gone submittively? We really don't know. But when you come to this side branch, again, it has gone into the side branch where you can see the wire here. So, but anyhow, something was happening. We had difficulty there and we did this OCT, showed it like that. So we had no other option. Again, rewired it and then dilated it. And after dilating, well, we did a final OCT. So what is happening in the final OCT? You see here, there are struts only, this is the proximal segment here. There are struts on only one side and there is no struts on the opposite side there. So basically when you reconstruct with this, you see that it's actually when I recross second time, probably abluminal cross here, and I have done a pot there, and then this pot has damaged this proximal part of the stent there. So then this is the reconstruction and no other option, like I had to put one more stent there and covered it and finished off this procedure. And coming to this dedicated bifurcation stent, this is a modification of Culotte. So you see here, you get 4 markers there. And then what you see is this is the branch stent. You deploy it in the side branch, and this is how you position it. And then this is the stent design where the side branch has a normal stent, but here the amount of metal is less in the main vessel. So the main reason advantage of this is only thing it's a modified Culotte where the amount of metal in the main vessel may not be so much rather than when you are using a 2 stent strategies. So then after putting that branch stent there, you take a main vessel stent here, like any other Culotte, you just deploy there. And you can look into the wire crossing where which struts you are crossing, which we will not highlight. Then of course, final kissing is a must and pot is also a must. And generally you get such an image here. Many times it's an excellent result with excellent coverage with this technique. Only thing is probably it is a little bit more quicker than using a 2 stent Culotte, routine Culotte stenting there. So this is one thing, and these are some of the follow-ups of this branch stent, which we have done around 35 cases with 1 year follow-up. And this was a case where with the left main OM ramus bifurcation we have done. And you look at this, this is the index at 2018, and this is the index at 2019 follow-up. So you see a good endothelization, and the ostium is well preserved with a good result with this type of technique, dedicated modified Culotte stenting, dedicated branch stent there. And probably this I will be the last case. And this I was actually proctoring for one recent times here. Look at this LAD diagonal. And once this is the LAD diagonal, we planned to do almost equal size LAD and diagonal. He had a recent anterior wall MI for which he was treated outside, and this was the case posted there. And there was a reasonable space between the left main and the LAD in the proximal segment. And we planned, I think its angle is also not so large, or nor is it very small also. But anyhow, we thought of doing a culotte there in this case, so dilated the diagonal. And I did a OCT from the diagonal there. And of course, from the OCT, you know the reference diameter and all. LAD was almost more than 4, and diagonal was around probably 3 or 2.75 there. So only a challenge is, can you bring up this 3 size or 2.75 stent to 4 is a question here. Yes, definitely we can bring that science stent 3 to 4 point, up to 4.1, 4.2, you can do either. And with that idea, we went ahead and did this procedure. So deployed the LAD to diagonal stent there, and dilated very well. And I did a pot also there, used a 4-size balloon there in the left LAD, and dilated the stent there. And what happened is, and then I rewired the LAD. After dilating, I have rewired the LAD. Then tried to cross the balloon from the LAD, from the proximal LAD to the distal LAD. Sorry, they have mentioned it as left main. From the LAD, we could not cross at all. Multiple attempts trying to take the balloon, repositioning, doing everything. Nothing was going. So when you look at the stent boost, see, this was the balloon which I was trying to attempt, take it there. So LAD to diagonal, it was stented. And then I wanted to stent the LAD now, so rewired this, and then trying to take it is not going at all. So when you look at the stent boost properly, see here, actually there is an abluminal crossing here. There's an abluminal crossing of this stent going beyond it. So I did a OCT also from the diagonal to see what was happening there. So when you concentrate on the proximal segment, you see that there is some amount of stent deformation, which here you can see there probably. In the very proximal segment, it is deformed. There is the malapposition-like thing present there. And this is the angiogram. And when you look at the OCT run clearly, it was a well-opposed stent, probably because of recurrent attempts there to take the balloon there. There is some amount of deformation, which is looking like a malapposition. And you see the second wire here. This is the inside the diagonal wire. There's the second wire. It is clearly behind the struts. So these are the struts there. And you see the second wire very clearly behind the struts there. And even stent boost shows clearly that it's an abluminal cross. So this is can happen in any patient, like in any technique, like even in Culotte or with decay crush. And then it's a very important step that you should do a good pot. Here I did with a 4-size potting, but in spite of that, this has happened. And probably next what I did is I took a still bigger balloon and did a pot there with 4.5. But although we were not sure, taking a 3-size stent to 4.5, we had no other option. Removed this wire, did a good potting. So this is what I did here. So I did a very big, good potting with a 4.5 balloon there for this stent deformation. And then what I did is recrossed. And then recrossed here into the LAD there. And this was probably ideal wire crossing. And then now the balloon moved here. So then I took the balloon there, dilated there. And here I did not want to go ahead with Culotte, because if I'll have to again take out the wire and recross. So what I did is I just modified into a T. And then rather than pulling it back and doing a Culotte where I had to take out the wire and take a recross there, So to avoid that step, I just changed it to a T with slight protrusion there. And this is what I have done. This is the kissing getting deployed there. This is the final kiss and this is the final result. So, but actually this procedure took almost 1.5 hours crossing that first stent. We had to do so much of maneuver, and that is why I did not want to complicate with making it as a culotte and take to avoid recrossing there. And this is the final part, and this is the final OCT also, which you can see that there is an excellent coverage of the side branch here, and still images I'll show you. And this was the proximal part of the stent where there was something like a thrombus where we had manipulated too much, which I optimized with the balloon dilatation. This is after the optimization. And this is the bifurcation point here. So this is the LAD where we put the second stent. You see the ostium, the LAD well covered here. And this is the ostium of the main vessel, diagonal also well covered. So it doesn't mean that if you do a T that you won't cover the ostium of the side branch. Most of the time, if you just place it, we try to get good coverage. And your Karina, what we always discuss is really not too bad there with a good coverage and good figure of 8 image there. And this is the final angiographic result. But angiogram will always look normal, but imaging will give you in-depth idea what has happened there. Thank you very much. I think I'll stop here and not go beyond this.
Certainly, that is an excellent case. I think the problem was, this is with the pot. When you have the pot, I mean, you should probably take the balloon all the way up to the proximal stent. And that you can probably see with the stent goes. Here, if you look at it, probably the pot balloon was done, but the right ostium of the stent or the proximal most part of the stent was not dilated, which is probably why it had gone abdominal.
Probably that's a reason, because actually I was proctoring this case and I was standing with them. But I went into when the problem started, but it took quite a long time to recross it because of the stent damage.
Sir,
but when you have a tap, sorry.
Please go ahead.
Now, when you have a tap again, the second pot, the last pot, it's very, very critical because you have to have the balloon away from the carina, because you will have the neocarina, which the layer jutting into the lumen. So if the stent or the balloon protrudes in, then you will again cause deformation of the neocarina. Yeah.
Yes, sir. Even the problem in the initial case, the one with the branch stent, the one you have stented into the OM branch, and then you found that the wire was substrate. And again, there also, I thought probably the pot that was done probably did not reach till the carina. It was a more proximal pot. Probably it was not done till the proximal end as well as till the distal end. So initial wire, it went substrate more distally, and you took out the wire and then you rewired it. Probably the wire went in substrate proximally. So again, the message is probably the pot is more important. And again, one challenge with the last case is you made out in OCT that it was a 4 mm vessel, but the problem is, if at all it's a 4.5 millimeter vessel, if the calibration is not proper, then you might feel as if the vessel is 4 millimeter only, and you might end up having a 4 mm balloon pot. So if the calibration of the OCT catheter is done properly, this has happened to me, so that's why I thought I should share with you. If the calibration is proper, if it's not proper, a 4.5 millimeter vessel might look 4 mm vessel, and we might end up having a pot with a 4 mm.
How do you do that, Deepak?
No, sir. The green dots.
Initial,
the green dots.
You'll have to calibrate it properly.
That's not normally done, isn't it? So how can you have the calibration wrong?
So you need to have all the you see all the 4 green dots, right? At least 2 should be on the catheter. Many times we do not give a lot of attention to that particular step.
So in the last case, you already had a stent deformation, and then you have made it that stent to 4.5 with the OCT showing a 4 mm vessel. There should be a foreshortening, and wouldn't it have been better if you had done a proper culotte and covered that proximal deformed area well with the foreshortened stent, already having a foreshortened stent?
Yeah, that would have been better, but my idea was, again, we are trying to finish it up faster. It was too late. And then similarly, when you do a culotte, you'll have to remove the wire and again recross it, which step I did not want to do it in that case. So I just simplified like this and came out of it.
Right, Deepak?
Sir, thank you so much, sir. Thank you so much. Narayan, sir, you're muted.
The final word should be by you.
Sir, thank you so much. First, let me take this opportunity to thank everyone, all the speakers, the experts, as well as moderators, especially Narayan sir and Madhu sir, for being with us whole throughout the day, even though it was a Sunday evening. Thank you very much. I should also thank Anand for the audiovisual support and all the entire Abbott team for the help rendered. Thank you so much and good night. Stay safe.
Thank you. Good evening.
Good night.
Good evening.
Good night. Good night.